Good morning again, ladies and gentlemen. Please stand for the playing of the national anthem as we bring today's symposium to an official start. Kindly remain standing as I ask Miss Jenna Paris, tutor, Eardiston Teachers Training College, to come and lead us in a word of prayer.
Good morning. Please bow your heads. Almighty and everlasting God, we give you thanks for this opportunity to come together as an early childhood community. We entrust to your care those who are serving as participants, that you might strengthen them with physical and mental stamina to conduct their business with courage, mutual love, and spiritual centeredness. We pray for a renewed commitment to this cause, which is to ensure the development of the whole child and foster collaborations. Guide the delegates towards an unrelenting focus on that ideal, that it may guide every decision and discussion that is had. Remind us that true transformation begins in the mind and the heart. We pray for clarity in the way our organizations, programs, and activities may go. Empower us to negotiate the hard decisions wisely and to refrain from making some decisions harder than necessary. We pray for a reform for the right reasons, in the right ways, in the right areas. In this we ask, amen.
Thank you, Ms. Paris. Please be seated. I am Dr. Christina Morris, Senior Education Officer, Nursery and Primary Section in the Ministry of Education, Technological and Vocational Training. And it is indeed a pleasure and an honor to be the moderator for today's symposium. Honorable Kay McConney, Member of Parliament, Minister of Education, Technological and Vocational Training, Mr. Fayaz Shah, Education Manager, UNICEF, Ms. Shelley-Ann Harper, Early Childhood Development Specialist, UNICEF, Dr. Carol Jacobs, Deputy Chairman, Child Care Board, Ms. Roseanne Richards, Director, Child Care Board, Mr. Colin St. Hill, Deputy Director, Child Care Board, Dr. Junie Lynch, Senior Tutor, Eardiston Teachers Training College, distinguished presenters, staff of the Ministry of People Empowerment and Elder Affairs, staff of the Ministry of Education, Technological and Vocational Training, staff of the Child Care Board, staff of Erdiston Teachers Training College, participants, specially invited guests, members of the media, ladies and gentlemen, a hearty good morning to all of you. Good morning. Good. I'm going to invite Mrs. Gail Carter, preschool educator, Child Care Board, to bring the official welcome.
Thank you, Madam Chairperson. Protocol being established, let me say good morning to everyone. You look amazing. It is my task this morning, I'm going to ease my glasses off, I can't read with them, to give you the official welcome for this Early Childhood Development Symposium this morning. Partnership. A partnership is an arrangement where parties agree to cooperate to advance their mutual interests. Today, we are here as partners, working together with and for the children of Barbados as our mutual interests. We each play a role in enhancing the early childhood landscape of this nation. We all know that working with young children and their families can be challenging work and seems to get more challenging with each passing day. But we also know that in order for children to develop holistically, it must be a multi-sectoral approach. We have to come out of our silos and collaborate more. This is the beginning of that combined conversation. According to UNICEF's Nurturing Care Framework, all children need nurturing care to develop to their full potential. It is vital for healthy growth and development. The time from pregnancy to 3 years of age, when the brain is most susceptible to environmental influences, is crucial. Nurturing care not only promotes physical, emotional, social, and cognitive development, it also protects young children from the worst effects of adversity. It produces lifelong and intergenerational benefits for health, productivity, and social cohesion. Nurturing care encompasses the needs of young children for good health, optimal nutrition, security and safety, and opportunities for early learning and responsive caregiving. Parents, families, and other caregivers are the main providers of nurturing care. Policies, programs, and services must therefore be designed to enable them and their communities to meet the needs of young children. This symposium is a collaborative effort between the Child Care Board, Erdiston Teachers Training College, and the Ministry of Education, Technological, and Vocational Training. It is aimed at providing opportunity for improved collaboration among stakeholders in early childhood care, development, and education, to enhance staff efficiency through professional development, which is focused on providing better quality learning experiences for children and working with children with developmental delays, disabilities, and behavioral challenges. This symposium is bringing together colleagues within the field of social care, child protection,
I went to the World Education Forum in London, UK. And that was a four-day program. And coming up in the discussions on practically every topic was the fact that we need to go back to loving our way through the service we provide to these students. And that it is not just love in a notional way or even in a theoretical way, but it is how do we integrate safe love in practice. And so I hope that with all the important topics that I have seen on your list, which are absolutely necessary for us to do, that we will seek to infuse not just the notion of, but how do we practice safe love as we seek to do better by our children. And the centrality of love to the work we do with children as a country, it must be rooted everywhere. I am even more convinced so than ever because of my experience as minister responsible for education, technological and vocational training. Because the traumas that we are seeing manifested in children in their move through life in our school system have a connection to how they are being loved through their childhood. And I say to this forum, raising children is a love story. And for everything we have done and will do in the interests of our children, it will only be clinical and sterile and detached until we humanize it with love. And that deserves, I think, a deep dive in every topic. It must be cross-cutting in every topic that we bring to this table. Now, we as a country, Barbados, as all of you know, and you are products of that investment, we have invested significantly in education. And in fact, our Ministry of Education, Technological and Vocational Training, we are committed to enhancing our delivery of quality early childhood education across the system. And as part of our efforts to improve outcomes for children, we propose to increase access over the next 3 years through our expanded universal pre-primary education program. And what does that mouthful say? It says now that we provide mandatory access for students and learners from age 5 to 16. We propose to expand that access where those parents who wish may access our public system for early childhood education from as early as 3. It will not all happen in 1 year. We expect to stretch it over a period of time because you will understand we have to create customized spaces. We have to make sure that we have teachers suitably trained, and we have to make sure that the approaches that are proven to be most successful are those which we have prepared our experts to be able to engage with our children. In teaching, we recognize that the traditional teaching methods have their place, and they will get us only so far. Today, though, teachers must be more than knowledge experts who are imparting their knowledge on our young learners. You will notice that many of our learners now, through the internet and technology, are walking into not only our primary and secondary, sometimes our pre-primary rooms, knowing a lot more than we think they should know at that age. And so it is not necessarily that we are imparting knowledge only. That has to be a part of it, of course. But we now, as teachers and caregivers, must become facilitators of learning, where we are encouraging our children to take some ownership and responsibility for part of their process of learning. And so as we shift, not only from being teachers, but from teachers to learning facilitators, it will take a deeper dive into how we do so, and how we do so anchored in the love ethos. Of course, we recognize that the ways in which we have done pre-primary and nursery education over time has worked in some ways. But emergent research is telling us that play-based learning, when we make it fun for children to learn, they actually want to learn. And their relationship with learning going forward, it makes a difference. And I share that information regarding play-based learning because, again, our Ministry of Education will be investing in collaboration with some of our international partners in what is called a Center of Excellence in Early Childhood Education. Some people call it a laboratory school. And that laboratory school will focus on teaching along the streamline, meaning science, technology, reading, engineering, arts, and mathematics. And that we will do so with an important part of its instructional focus being on play-based learning. The work has begun already. The laboratory school will also serve as a center for research and training and will become a model for other schools that accommodate 3 to 4-year-olds. And in preparation for the lab school, we have already started a pilot project where 30 teachers were trained to date, have been trained to date. Plans are continuing with a view to us rolling this program out in the upcoming academic year. And for those, I don't want to keep you in suspense, it is the Maria Holden Nursery School at Gall Hill that is being prepared from the level of school leadership through the teaching practices to become that center of excellence. We will not reach excellence immediately, but what we want for you to do is to believe in the science, in the evidence, that if we make it fun for children to learn, they will want to learn. And therefore, we will be better able to create what I call, and what we at the ministry consider to be, a solid foundation. Because we are finding that those who are not doing well at the primary and secondary level may not also have been doing well at the pre-primary level, and may very well, throughout the system, have had challenges that were improperly diagnosed or not diagnosed at all. And therefore, the proper intervention, whether that intervention was from an educational perspective or a social services perspective, may not have happened at the best time for the child to be able to derive the best outcomes. And that's why all of us are in this room, because we recognize that this cannot be done by nurseries alone. It cannot be done by primary schools and the education system alone. It will take all of us working together. And I know that we're seeking to build a stronger relationship with the people from People Empowerment and Child Care Board, so that we are able to provide wraparound services. Because oftentimes when you find a child in our system with a problem, you can often pretty much be sure that there is an environment with a problem around that child. And the interventions have to be made across the board. Our teachers have to know how to identify, how to de-escalate, and then when to escalate to other agencies. We need to have the systems in place that when we speak with each other, or we communicate and collaborate with each other, we get a quick response, particularly when we have a child in crisis. We need not only to think about those in crisis, but we need to think about those children who are moving at a faster pace than anyone else in the system. We may call them gifted, some call them exceptional. By whatever name we call them, we recognize that they're children with different needs at different times along the system. And we have to be able to put the kind of profiles together, and it have to be holistic profiles that allow our various systems to know how best to intervene, whether at a teaching level or at a social services level or at a parental level. Now, I know you have a symposium of 2 days, and I have a cabinet meeting to get to by 10. And so I hope I'll have the opportunity after this symposium is done and we come back together in a different kind of way to truly understand what progress we are making. I'm asking that this symposium not just be about discussions, but about things we can practically do, even if we do them as pilots. What can we practically do in some of the specific areas that are going to be covered that will allow us to move the needle on this? I close by reminding you that we don't have a lot of time to do this. I say it now, and I will say it at nearly every time I speak. We believe that the world is changing and has changed at a fast pace, correct? But guess what? Even with the discussions coming out of the Education World Forum a couple of months ago, what is clear is this is the slowest time at which change will happen for the rest of our lives. Generative AI has changed the game. Generative artificial intelligence has changed the game. And so I'm saying to you, if you think we have time, we don't. And if we fail to do what we have to do now to lay a solid foundation to set our children on the path to success, we too must live in a world with these same children once they grow up. And so to all of you, I wish you a most productive symposium over the next 2 days, and may everything you do be anchored in love. Thank you.
Thank you very much, Minister Makani. You have reminded us about the importance of partnerships, of stakeholder engagement. You have reminded us about the importance of providing service and education with love. We have also been reminded of the government of Barbados's continued investment in early childhood education and the commitment to improvement. The area of access, so that we can assure that there are more places made available to 3 to 4 year olds, was also highlighted. Teachers of facilitators of learning. You have heard about the play-based learning approaches which the Ministry of Education has been turning attention to, and we want to re-emphasize the importance of that. We have been informed of Ministry's plans as it relates to a school of excellence, a laboratory school. I agree with the Honorable Minister, colleagues, that the time for action is now. And that is certainly in keeping with the theme which has been identified for the symposium: ready, set, go. The future is at our fingertips. Please join with me again in saying thank you to the Honorable Minister Makani, Minister of Education, Technological and Vocational Training. And as we continue to recognize our partners Thank you, Minister. Do travel safely. As we continue to recognize our partners in education and the provision of early childhood services, it gives me great pleasure to welcome to the podium Mr. Fayaz Shah, Education Manager, UNICEF. And all of you, I'm sure, in this room know of the excellent work which UNICEF continues to do in Barbados, in the region, and across the world. Please join me in welcoming Mr. Shah to the podium.
Thank you. A very good morning with all protocols observed. I bring gratitude and good wishes from UNICEF representative for East Caribbean Area Office, Mr. Peter Bolt, to all of you, specifically to the Child Care Board, to the Ministry of Education, Ministry of Health, and Edison Teachers Training College. Thank you for organizing this very important symposium. Colleagues, I really don't have to say much at all. The theme of the symposium says it all. Ready, set, go. The order in which these three words appear is very important, meaning you must be ready before you can go. And ready in our UNICEF program term means first 1,000 days of child's life, spanning from conception to the age of 2. These are profoundly critical years for their development and future well-being. You know, there is compelling evidence that investing in the well-being of children during the first 1,000 days pays dividend not only for individuals but also for society as a whole. From nurturing care to optimal nutrition, every aspect of child environment during the first 1,000 days lays the foundation for their future development. Just to name few, the rapid brain development that lays foundation for future learning, behavior, and health. The nutritional foundation lays foundation for cognitive development and immune system. Emotional bonding, leading to sense of belonging. Language, motor skill development, establishing healthy habits, and prevention of health issues. These all are so important. If I can maybe put it in a cricketing term, we know the World Cup is going on. If you lose 8 wickets in first 6 overs, the power play, they call it, the power play overs. If you lose 6 wickets, are you gonna win? So not attending early childhood 1,000 days it's like losing 8 wickets, because the areas I mentioned, they are 8. From very important one, the brain development, nutritional foundation, emotional bonding, language, motor skills. So these 1,000 years are so important. I would like to emphasize here that it's not just child, but in UNICEF we say every child. Surety for every child that relies on early detection and early prevention. Madam Minister also mentioned that. To date, this opens and UNICEF is great advocate for window of this opportunity for early detection and early prevention. It detects development delays, health concerns or social emotional difficulties, and ensure early prevention and timely support that can mitigate the effects of risk factors and promote positive outcomes. Therefore, we emphasize the importance of screening and early intervention services. My colleague, Shellyanne Harper, who is leading the early childhood program in UNICEF, has started this very successfully in Trinidad and Tobago with the Ministry of Education, and we hope this program can be rolled out everywhere in all the countries which are interested. Just one more point, I will not take a lot of time. UNICEF East Caribbean Area Office, as I said, led by Shellyanne Harper, makes emphasis on integrated approach. And it is so encouraging for UNICEF to see that here is, in this symposium, we have Ministry of Education, we have Ministry of Health, together with caregivers, together with teacher training colleges. So this is really very encouraging. And the minister mentioned the School of Excellence. I think UNICEF would also like to be part of contributing to that, because we are also working with Ministry of Education in the Caribbean, in Grenada, to establish the same, bringing everybody together and try to integrate and come up with an approach that all concerns are involved. It is because, early childhood development encompasses various domains, including cognitive, physical, social, and emotional development. Effective program recognize the interconnectedness of these domains and provide comprehensive support to address children's needs comprehensively. Once again, I would like to thank you for this opportunity and wish all the success to this very, very important event, this symposium. Thank you very much.
Thank you very much, Mr. Fayez, Education Manager, UNICEF. He has shared his thoughts on development, the role of nutrition, the emphasis on the development of every child, the need for early detection and prevention, the emphasis on the use of integrated approaches, and in this regard, the fact that UNICEF is working in collaboration with the Ministry of Education and the Child Care Board on today's activity, which will continue tomorrow, also helps to strengthen the collaboration and the integration across the sectors. I was very pleased to hear of your offer of assistance to the Ministry of Education as it relates to the establishment of the School of Excellence, and I will be sure to share that with the Chief Education Officer, who I know will share it with the Minister of Education, and you can be assured that we will be contacting you. Ladies and gentlemen, we have reached the end of the opening ceremony for the symposium, organized for us to explore early childhood development. I would like to once again thank all of the speakers who addressed us this morning. Ms. Paris for invoking God's presence, Mrs. Carter for her warm welcome and setting the context for today's discussions, the Honorable Kay McConney, Minister of Education, Technological and Vocational Training, for her words of wisdom, encouragement, and we have been asked to ensure that everything we do and discuss over the next 2 days is done with the view of ensuring that love is the key. Thank you again also to Mr. Shah
Again, just to give you a summary of the presentation, we're going to talk about the diets of Barbadian children, which I am almost certain that all of us have an idea about. And again, the first 1,000 days, and then we're going to look at some nutrition landmarks or some nutrition milestones during a child's life. Now, in terms of the dietary patterns in Barbadian children, it often leaves me troubled. And let me first say that the diet of a child is generally a reflection of two things. One, their food environment, and the second thing would be in terms of their consumption patterns at home. You know, so food environment, whether it be school or home, and also parents and guardians, they should tend to they would give a reflection of how a child eats or how a child should eat. Key thing here is that multinational and national food companies continue to target, market, attract children. And this marketing and attraction is really to kind of push these unhealthy foods, sugar-sweetened beverages, and of course the ultra-processed foods. Funny enough, I just saw one of the toys over there, and it was like a can opener thing. And one of the things was I think was some luncheon meat and maybe some kind of sausage or something like that. Again, troubling things, right? Good. Again, but the challenge here is that these food companies tend to market to children. And again, they don't do it because they want to market to children. I think they know and they appreciate. And we know and we should also appreciate that if you get a child to like or to prefer a product from very young, oftentimes you have a customer for life. When I worked at the clinic more, I would see patients and they would say, I was drinking this dark brown sugary beverage from the time I was a child, and they are 65, 60, 70 again, and they still say, oh, I love this drink. Yes, a Coke, they love it. Do you love it as well? Don't answer that. But the key thing here is that, I don't know, in years gone by, we would see some of the fast food companies donating things like pencils, book covers. When we go to the drive-thru, you will get toys as well too. And again, these things are not done, again, because they love children, at least not really, right? Again, these things are done to kind of get children attracted to their product. And that's very important. There's a well-known soft drink. It's roughly half this size, and some of the other manufacturers actually produce these drinks now, and they're roughly about half this size, so they fit into a child's hand perfectly. You know, and so all these subtle things and the not so subtle things are things that we need to be cognizant of as parents and teachers and guardians and as people in general. Now, just to give you some other boring statistics, again, but the key takeaway from this slide really is that children and Barbadians in general, they don't consume adequate amounts of things like fruits and vegetables. And that's key. And a critical component of fruit and vegetable consumption is one, children have to develop a taste preference for it. And the taste preference normally starts very early in life, 1, 2 years. So if a child is living in an environment where things like fruits and vegetables aren't readily consumed, high sugar beverages and ultra-processed snacks are readily consumed, we can only imagine that they're going to have this taste preference for these high sugar, high sodium, high fat foods from a very early age. Even some of the infant formulas, for instance, some of them are loaded with sugar, and these cereals as well too. So one can imagine that when a child is exposed to this high sugar intake from a very early age, as they get older and they get into the school setting or the school system, their taste preference is already decided, so they're not going to want to have the apples and the bananas that the school meals may actually serve, and oftentimes those things are wasted, even if they serve maybe some kind of vegetable as well too. Another key thing here I also want to point out is that there's a high consumption of sugar-sweetened beverages, and that's very important. I was at a school yesterday speaking to a group of class 4s, and when I asked the question, how many students consume a sugar-sweetened beverage on a daily basis? All the students said, we do, and again, some consume multiple sugar-sweetened beverages on a daily basis. And I think that's very important, again, because it's just empty calories and loads of sugar. Now, let's touch on this first 1,000 days. And I imagine everyone here would have heard it, even if they can't expound on it in any great detail. But the first 1,000 days is very important. And again, it's the period from conception to a child's second birthday. And during this time, key milestones are reached. And believe it or not, optimal nutrition is important to prevent NCDs and obesity as a child ages or as a child gets older. And that's very critical as well, too. Now, I'm going to just touch briefly on some specific time periods in a child's life. And again, we cannot start the discussion of healthy lifestyles. Again, you want to do it as early as possible. So you shouldn't wait until the child's in primary school, you shouldn't wait until the child's in secondary school. These things can begin early. And the key thing here we need to understand or remember is that parents and guardians should model, teachers as well, should model these healthy behaviors. And that's very critical in terms of this behavior modeling. It's very, very critical. So it's all about having the food environment as one where the healthy choice is always the easier choice. Very important. I think we talk about this idea of having a balanced diet or eating healthy. And again, just to kind of distill it down to simple terms, a balanced diet basically means eating a wide variety of foods. And of course, avoiding the high sugar, high sodium beverages and ultra processed snacks, but eating a variety of foods. But again, the typical Barbadian experience is one where we generally have some kind of very large serving size of carbohydrate, whether it be rice, some kind of pasta dish, and a very large serving size of protein, or what we say of food from animal. And that is key. The variety or the balancedness of our typical Bajan diet is one that is not there. And I mean, I've heard it over the years. People say, well, these vegetables and fruits are too expensive. My child doesn't like this particular fruit or this particular vegetable. But a big part of it comes down to how we train a child and select for a specific taste preference. And that's very important. Now, again, the idea of preconception. Now, in terms of some nutrients that are critical or important, preconception and pregnancy. Again, the key things here, folic acid, iron, calcium, and vitamin D, these things are key. And as long as a person would have a balanced diet or have some kind of balance in their diet, you would tend to get all these, so there wouldn't be a deficit of these specific nutrients. During pregnancy specifically, parents may be advised to supplement with a folic acid supplement, for instance. Also, a lot of the foods and cereals that we get now, they're also supplemented. They may also contain the folic acid, the calcium, the vitamin D as well too. So these things occur in some of the foods. I caution parents about things like breakfast cereals, again, because of the high sugar content as well too. But again, as long as you have a balanced diet, having your fruits and vegetables every single day, there's no challenge in terms of not getting adequate amounts of vitamins and minerals in your diet. Another key component here is the omega-3 fatty acids, or what we call the fish oils. That is the typical source, but you get it in things like flaxseed, you get it in things like walnuts as well too. And again, these omega-3 fats actually support optimal brain development and cardiovascular development as well. Now, I want to touch on this 0 to 6 month time frame, and the key thing here is that breast milk is always best, and that's the key thing. Breastfeeding is always best, and breastfeeding is very, very protective. Research shows that children who are breastfed exclusively for 6 months, as much as possible, they tend to develop optimally compared to a child who may not be breastfed, and that's very important. Breastfeeding supports optimal weight gain as well, so breastfeeding is very important. Of course, in our busy society, it's not always practical to breastfeed exclusively, but the key thing here is that I encourage mothers anyway, to breastfeed as often as possible, but breastfeeding is key. Now, this key point here, 6 months to 24 to 4 months, weaning is where a parent should introduce different foods to a child. Again, the key thing here is that I often tell people, avoid the high sugar, high sodium, high fat snacks, and high sugar beverages. I think when I worked at the clinic more, the typical thing that I would see parents giving children these sweet snacks or these sweet beverages in an effort to kind of pacify them or keep them quiet. But the key thing here is that these snacks and these beverages are very bad for their health. And I think what we see immediately when a child consumes high levels of these sugar-sweetened beverages, we see them with lots of dental caries, and that's very important as well too. So limit the sugar as much as you can. Again, just to talk about things that we should avoid, I think all parents are advised to, especially pregnant parents, pregnant mothers, are advised to avoid high levels of heavy metals which are found in these very large predatory fish, excess vitamin A, excess caffeine, and of course, alcohol is definitely a no-no. Definitely a no-no. And again, the key nutrients, sugar, salt, and fat. And again, these are found in the sugar-sweetened beverages and also the ultra-processed foods. Again, the tendency is for persons to give them as snacks, whether a child is going to school or whether a child is at home. But the key thing here is definitely try to avoid giving children these in excess. So it's not a question of a child cannot have a snack on occasion or a sugar-sweetened beverage on occasion, but the problem is really going to come in when a child has these things every single day, and that's really the problem. So it's not about abstinence, it's really about, I hate to use the word, but moderation, or even a bit more moderation. And again, as I reach the final slide, I think the key thing here is that I want people to understand healthy eating doesn't have to be some mystical concept that you hear about or you see. Eating a wide variety of foods, that's the most important thing. Wide variety. And this last bit of research just really says that if a child lives in a household where one parent is obese, he or she is at 50% risk of becoming obese themselves. And if both parents are obese, this rises up to 80%. And the key thing here is that children who are overweight or obese during childhood, they tend to maintain that into adulthood. And of course, with the obesity comes things like elevated blood pressures, elevated blood sugars, cardiovascular issues as well. Thank you.
Good. We're going to go into our next presentation, which will be done by Professor Margaret Ann St. John. Professor St. John received her secondary education at Queen's College, graduated from the UWI Faculty of Medical Sciences, completed residency training in pediatrics in the USA, and ambulatory fellowship, and at the Hospital for Sick Children in Toronto, where she was a resident in pediatric ID. She served in the public service as a QEH consultant for 4 decades, being head of department at one time and contributed significantly to the development of the department. Later, she served as an honorary consultant in pediatrics. She became an honorable professor of child health in the Faculty of Medical Sciences Cayfield campus from 2010. She has presented and authored more than 150 peer-reviewed articles, is an international journal reviewer, and has received multiple awards for her research and service to pediatrics. She has received the Rotary West Vocational Award, was a Kiwanis awardee, UWI Pelican Award for shared Best Medical Graduate of the 70s, was a BAM awardee 2016, and a national awardee, receiving a Gold Crown of Merit for national contribution to pediatric services in Barbados, and a national awardee for service during the COVID-19 pandemic. Professor St. John has also served as a volunteer medical advisor and crew member to Variety Children's Charity in Barbados for several terms, and serves as other local children's charities and as a resource person. Her passion and energy remain focused through contributing towards improving the quality of health and life for children in Barbados. And in the last decade, the focus was on prevention of childhood obesity and non-communicable diseases in Barbados. She is a very strong supporter for the intervention and implementation of the Barbados SMP, schools. Yes, the school's national nutrition policy to promote healthier nutrition as being one of the rights which the children of Barbados are entitled to. Please welcome Professor Margaret Ann St. John as she presents on early childhood illnesses.
Nutrition. Nutrition.
Good morning. I'd like to thank the organizers of this symposium for inviting me, the kind invitation, and the sponsors. I won't go over the names, it's already been mentioned. So in order to be able to utilize the time to the maximum, I'm going to speak about early childhood illnesses. The light is not very good, however, I hope those of you on that side can see very well. Thank you for the kind introduction. So, knowledge is power and empowerment is key to optimal health. And I'm going to speak about some common early childhood illnesses, both communicable and non-communicable diseases. What are the signs of serious illnesses, detection of the signs of serious illnesses, and what you should keep in the medicine cupboard. I hope that you will go away with some messages, take away information, learn something new during the presentation today. First of all, fever, basic. The child with a high temperature is quite frequent in young children. And we take 38 degrees C, or if you like Fahrenheit, 100.4. The temperature usually returns to normal within 3 to 4 days, with or without fever medicine. And we find sometimes parents and care providers panic. They want to almost sometimes poison the child with fever medicine because they have to get it down. But however, it's self-limiting, and the temperature is the body's natural response to fighting infections like colds and coughs. Most viral illnesses start with a fever. So many conditions cause a high temperature in children, as common childhood illnesses like chickenpox, tonsillitis, even vaccinations, you expect a temperature and sore throats. And that will go down by itself even without medication, so there's no need to panic really, except specific circumstance which I'll mention later where you need to pay a bit more attention. A child may have a temperature if they feel hotter than usual, and strangely enough, when children come to be seen, the parent says they have a temperature, and you measure with a thermometer and it's normal. So the temperature reflects the environment. If you're in a place where it's cool and you feel the child, they may feel warmer and they have no temperature. But parents and care providers like to rely on feeling the head and the skin, the back and the tummy. If the child feels sweaty or clammy or has flushed cheeks, depending on their color of their skin, the temperature may or may not be elevated. So investing in a thermometer is very significant. Looking at respiratory conditions which affect between your nose and your chest. They're mostly infectious diseases which young children contract, spread from person to person, like the common cold or influenza. More recently, COVID has been very much in the forefront and vary during the year. Most colds get better 5 to 7 days. They're self-limiting. And despite whatever 3, 4, 5 cough syrups, you cannot change the course of the illness. But parents and care providers, they want the stuffy nose to go away today. They want the cough to disappear by tomorrow. And so sometimes we find that children are toxic with too much medication. Sometimes in a young child, the cold can last up to 2 weeks, and allowed is 6 infections per year. This is part of the normal situation with the immunity of the child. I'll explain. When the child is in the mom, the baby, the antibodies are passed over from the mother. Now, by 1 year, the antibodies tend to disappear that were given by the mother. So if the child is breastfed especially, the antibodies continue to be passed through the breast milk, specific antibodies. So the child is not likely to get ill in that period of time, but after 6 months, the antibodies tend to wane from the mother. So you expect that the little child is going to contract illnesses when they're exposed, and how they develop immunity, they build it up by being exposed to infections. So 6 per year, sometimes colds, coughs, diarrhea, all sorts of different things. And in this case, when they have these infections, they should not attend nursery school. Now, this is something which is not, it is a public health recommendation. However, it is not practiced to the fullest, and this can be a reason why multiple children within a setting contract one type of illness. So, to be fair, people who are operating the nurseries and care centers, even schools, should not accept children when they see they have runny noses and cough. They should be out of school. This was implemented during the COVID pandemic. They should be out of school for 5 days because they are at risk to giving other children the same infection. Next topic is bronchiolitis as opposed to bronchitis. They're two different things. And this presents in the young child with a cold-like illness and wheezing. Again, it's self-limiting. By 2 weeks, the bronchiolitis should usually settle. Ear infections are also not infrequent. Sore throats. Most illnesses which are going to affect the respiratory tract present with a soreness of the throat and decreased appetite. And by day 2 to 3, the soreness is gone and it's gone lower and forming a cough. So you may find the child has tugging of the ears, fever, and irritability for a day or 2, and then they start to feel better. Acute sinus infections and nasal allergies, also prevalent, treated with antihistamines and nasal inhalers if it's a long-standing nasal allergy condition. Now, non-infectious is asthma. Runs in families oftentimes, or families where they have allergic type diseases, presents with recurrent colds and wheezing. Anyone who has wheezing with a cold more than twice, usually over the age of a year, is usually diagnosed as having asthma. And it usually disappears. It doesn't affect you that much when the child is older because they have built up antibodies to many of the infections. So these are treated by syrups and inhalers as well. Gastroenteritis, you're probably familiar with, spread again person to person. Hand washing is very important when you're caring for these children. They have vomiting, diarrhea, sometimes fever, lethargy. They need to remain at home because they're infectious. Virus is coming out in that bowel movement. And make sure they have lots of fluids. Now, the fluids I'm going to mention, I'm not mentioning Sprite and Coke. I'm not mentioning ginger ale. 16 teaspoons of sugar per serving is not going to help. So water, coconut water, barley, non-dairy milk like soy and almond milk, and oral hydration fluids. Small sips, continue breastfeeding, and small feeds if tolerated. The child improves with time. Again, a self-limiting illness. They do not need to eat to live. What you need to live is fluid, some sugar, fluid. And specific foods are not prohibited. Paracetamol, if in discomfort, meaning they're rubbing their tummy or they're not feeling so well and they're crampy. The vomiting may last 1 to 2 days, the diarrhea 5 to 7 days. However, if a child's symptoms last longer and they have blood in this diarrhea, high fever, lethargy, or showing signs of dehydration, like not passing urine, pampers are dry, seek medical attention. Moving on to another condition, fever, convulsions, or seizures. These affect children who are between 6 months and 6 years. There's a genetic tendency, and it can happen when a child has a fever. It's not related to the height of the temperature. This is where parents tend to panic because many people know someone's child who has seizures with fever, hence the panic and hysteria related to it. But if in your family there is no one who has had fever, seizures as a young child, it's highly unlikely that your child is going to have febrile seizures. The seizures are short most of the time. They do not affect the brain's function because they are very short, and recovery is complete. The child may, for those who have not seen a seizure, the body becomes stiff, they lose consciousness, their arms and legs twitch, and some children are incontinent of urine and stool. They may vomit, foam at the mouth, and their eyes may roll back. It's very frightening to see a seizure if you've never seen one, especially if it's your child or a bigger person having a seizure. What's recommended is to turn the child on their left side so the stomach is down. So if they vomit, that the vomit does not go into their lung, and head down. Do not feed liquid or food. Worse still, don't put a spoon or your finger in their mouth because you're likely to get a bite on your finger. What's recommended is transport the child to the hospital or emergency room. And if it's the first seizure, or if it lasts longer than 5 minutes and showing no signs of stopping, they definitely need to be carried, depending on the age, to the center. If suspected, the seizure is being caused by something else, like meningitis. For example, the child has been lethargic a few days, very high fever. If they're having breathing difficulties, they need to be checked. However, most febrile seizures, if it's just a seizure with a little bit of temperature, they will recover in about 5 minutes. If it's a repeat seizure, it's not usually necessary to take them to the hospital. Moving on to sepsis and meningitis. These two conditions can be fatal. This is the most serious thing that can happen to a child, especially a young child. So there's no single sign of sepsis, which is bacteria in the bloodstream, or meningitis, which is inflammation of the membranes around the brain and spinal cord. Babies and young children are most at risk. Now, this is the reason why we have immunizations at 2, 4, 6 months, a year, 18 months, 4.5, and 11 years, and every 10 years thereafter. Immunizations have been given. They have been given for years, and this is the reason why in Barbados and many countries now in the world, where we have immunization for 7 expanded program of immunization, WHO-sponsored vaccines, we do not see cases of meningitis and pneumonias like we used to, and we have not had a case of meningitis in the QEH for a number of years in children because of the vaccine. It's recommended to go straight to accident emergency or call an ambulance if the child has any of the following symptoms. If the child is blue, pale, has blotchy skin, lips or tongue, difficulty breathing, grunting noises, breathless, breathing quickly. If they are weak, have a high-pitched cry, which is not like their normal cry, and if they're not responding like they usually do, or not interested in feeding or any normal activities, and sleepier than normal, difficult to wake, and this is an emergency, and you need to seek medical attention. What are some of the symptoms of a really ill child which needs urgent attention? If the child has any of the following: difficulty breathing, breathing fast, not interested in feeding, they're dehydrated, and by that I mean if their mouth is dry, the saliva is just sticky, their eyes are sunken, no tears, they're very drowsy, their nappies are not wet for the last 6 to 8 hours, or the soft spot on the top of their head is sunken. The soft spot is usually here. When they're born, you feel this little dent there, and it closes usually by 18 months of age, so up to a year. If you feel the soft spot and it's sunken, it means the child is likely dehydrated. If they're becoming drowsy, very sleepy much of the day, irritable, you can't settle them, and especially if they remain drowsy or irritable despite their fever coming down, that is indicating they may have meningitis. They need to be taken to a healthcare center or the doctor. However, if none of those are present, continue providing care with the child and give them some fluids. It can be difficult as a non-medical person or in healthcare to know that your child is unwell. You trust your instinct. You should get medical help if needed. If you are second-guessing yourself, you need to take them. It's okay to say, well, there was nothing found. That was okay. It's not a waste of time. The important thing is to prevent condition being fatal. And signs of very serious illness, if they're mottled, cold to touch, pauses during their breathing for up to 10 seconds, grunting, if they're stiff and rigid, or they're jerky movements of the arms and legs, if they're very agitated and you cannot console them, they're crying so much. If they have a rash on their skin, a particular type of meningitis can cause that. And if under the age of 3 months, their temperature remains over 38 degrees or 100.4 Fahrenheit or above, unless they've had a recent immunization, they need to be seen immediately. I'm going to move here from respiratory conditions and meningitis to skin rashes, because these are conditions which, when you're in the nursery setting, may cause the child to be out of nursery. And these are contagious conditions. There is also non-contagious, spread between other children. And public health regulations must be observed to be able to maintain good health in communal settings like nurseries. The hand, foot, and mouth disease, I am sure many may be familiar with the term. It's a virus called Coxsackie. It's common in young children, and it's again self-limiting between 7 and 10 days. The first thing develops is soreness in the mouth, a high temperature, and the child doesn't want to eat. A few days later, there are ulcers, sores in the mouth, a rash develops on the skin, can be itchy on the body, and to help ease the symptoms, prevent dehydration, try to push fluids and give fever medication. Mouth ulcers and gels and sprays are usually recommended, and it's self-limiting. By day 5, the rash is gone, the mouth is improved, and they can return to the nursery. The next one is chicken pox, which fortunately we do not see. Chickenpox vaccine has been administered in Barbados for at least 15 years. And fortunately, we don't see chickenpox. Being on an island, we often would not see chickenpox. And once we see a case, it's somebody who came from overseas travel, or you traveled overseas and you were exposed to someone with chickenpox. The vaccine is available for all ages, and I recommend those of you who are involved with children, you should have a chickenpox vaccine if you are probably older than 20, because before that, we were not given the vaccine. It's not worth your while to have chickenpox as an adult. You can get pneumonia, you can get encephalitis, and you can get ear infections with chickenpox. It's not good for an older person to have. The next condition, measles and rubella, German measles. I'm sure you've heard much about this. Again, preventable by 2 immunizations, given at a year and 18 months. Presented with fever, cold-like symptoms, and a generalized itchy rash. Extremely contagious and not nice to have as an adult. We were given MMR immunizations from about 1977 in the public sector. So if you were born around just about that time, you should be immunized, protected for that. You should note, antibiotics or medication do not cure the conditions. They're self-limiting, which I have mentioned above. However, the children should not be in school until they're medically cleared. Other rashes you may encounter in your work, especially nurseries, schools, eczema, which is a non-infectious condition, runs in families, also called atopic dermatitis, treated with creams, lotions, and ointments, and it can be quite impressive in the young child, depending on how severe, but by adolescence, you don't often have problems with it. They are out of nursery if the skin is infected, but generally speaking, they can be in the nursery on treatment. Insect bites, and we are in the tropics, so we cannot get away from the grass flies, the sand flies, and also the mosquitoes. So those are also visible, but they cause nurseries to have the child seen by the doctor. Moving on to non-communicable diseases, predominantly, and the big focus, overweight and obesity. And Brian Payne really gave a very interesting presentation, the first 1,000 days of life. 1 in 3 children in Barbados are overweight or obese. The causes being multifactorial. High intake of sugar-sweetened beverages of all kinds, ranging from sodas to those lovely things that are marked nutritious juice. And you have to make sure it's pure juice, because oftentimes the first thing on the back food label is water, then sugar, and then flavoring. They are not pure. They can contain, sometimes the sugar-sweetened beverages can contain 16 teaspoons per serving. You have to look at the servings. Sometimes it's 1, sometimes it's 2, if it's 500 mils, 16 teaspoons. And I often see parents, when I worked at the QEH, parents have their children in clinic, and the child gets hungry mid-morning. They didn't bring anything. They'll go to a machine and punch in a soda. That's what they're giving, because they didn't prepare themselves to bring something down. And they're punching in the potato chips and the corn kernels, which are high in salt. So amongst the multifactorial reasons for obesity, high sugar, high intake of saturated fats, high intake processed and ultra-processed foods, excessive food portions. Now, we still love, in our culture, the child who is looking well. And looking well is that they're 1.5 times the weight they ought to be. It is also prevalent in the Spanish culture and other cultures across the world. The child who is normal weight for height is regarded as undernourished in eyes. And you can see, if you're looking at 20 children in a school, 1 in 3 being overweight and obese, that the child who is a normal height and weight would be regarded as being undernourished, because in every 3 children you see, 1 is overweight. Other factors include excessive, the food portions I've mentioned, unhealthy snacks, and we try going through the schools, which is the Barbados Childhood Obesity Coalition, of which I'm the chairperson. We're going through 75 primary schools and 21 secondary schools with a message at assembly on the mornings. We're going through in rotation, given a little education on food, nutrition, and the school's nutrition policy, to say that unhealthy snacks, water is important. Ministry of Education, I give them kudos. Water Wednesday, Fruit Friday. You can have water every day. They take their water bottles. Avoid them having sugar-sweetened beverages. They cost so much more money. I looked yesterday in the supermarket at the various waters available on the shelf. The cheapest I found was 99 cents for 500 mils of water. You know how much a soda costs. So there is a great savings. I don't think parents are aware that instead of is what we're trying to spread the word. Instead of unhealthy snacks and drink, give healthy snacks. An apple instead of potato chips. Grapes instead of potato chips. Substitution, and it will help a lot. Insufficient physical activity. On this slide, which you might not be able to see, definitely can't see, the built environment, meaning that people are living enclosed, especially the COVID pandemic has not been helpful. The child who would be running outside and playing in the swings is now inside looking at the tablet or looking at a cell phone. So that physical activity has been curtailed. We have to get back into running around and playing and put the tablet, turn it off and put it on the shelf in the afternoon. Let the child run about. You have to be with them as well. Tablets and cell phones have become babysitters for a lot of the world, parents. Large portions. Now, you can't see that slide, but the World Survey, Global Dietary Based Study on Consumption of Sugar and Nutrition shows that Barbados consumes, if you can see that, the red block, we are consuming 3 times as much sugar as the rest of the world. If you look at protein, vegetables, water, and so forth, they're similar across the globe, but Barbados has 3 times the global average consumption of sugar. The next factor and last one, genetic factors. Now, when I point out to the parent or care provider who comes, this little child is overweight for the height, they will tell me that the family is big-boned. They will say the child was large from birth. All kinds of explanations are given because that's the rationale that they have. However, there are standards which we have in place, and we should be trying to do something about that. Moving on to non-communicable diseases, non-infectious, developmental conditions. I cannot complete this talk without mentioning birth defects that are important in the first 1,000 days of life. Birth defects which are not picked up. Many can be diagnosed in advance by fetal ultrasounds. Sometimes they run in families. You can do blood screening. So they're important to note. Developmental delays, such as physical delays. We have a wonderful green health book. A lot of time was taken to develop that book, which has immunizations. It also has developmental milestones in it to see what the child should be doing at various ages, smiling, sitting, walking, parameters like that. And parents often do not use that book as it should be used. The weight and the height are in there. Looking at speech development, the age the child should be speaking, 20 words at 1 year, and so forth. Because these are really important to detect early, and interventions very important. As the Honorable Minister mentioned today, I'm pleased to hear about that special intervention that they're having at the Maria Holder, one of their nurseries. Socialization, important. The time of the COVID pandemic revealed a lot to us. A number of our students are behind in their development. Articulation, a number are being diagnosed with childhood autism spectrum disorder. Learning disabilities to be detected early. Attention deficit and hyperactivity disorder. Behavioral challenges, these are all illnesses as such. Early detection and screening, hearing from day 1. Mental health conditions can present quite young. Resources are available, so For those of you who have younger relatives who have young children, the Barbados Health Book is very useful. Prevention is better than cure in the long term. Interventions made at one, common entrance exam time, when you discover the child is getting 15% or 0, could have been probably detected much earlier. No child should be left behind. Medicine for the cupboard: painkillers, rehydration liquids, thermometer, antihistamines, teething gels, saline drops, plasters, alcohol wipes, and antiseptic cream. These are good to keep in the cupboard for any time. So my time is up, about a minute spare, and I would like to thank you for listening to this presentation. There are so many things about young children that we could discuss and raise, but I decided to select these particular items because I wanted to make sure that these at least were covered. Thank you very much.
Thank you, Professor St. John. Colleagues, at this time, you will have the opportunity to ask a few questions with the emphasis on few. As we engage our presenters, as you seek clarification on anything said during the presentation, the floor is open for a few minutes. Who wants to be first? Show of hands. Thank you very much. Please use the microphone. And please indicate who you're directing your question to if it is specific to presenter.
Good morning, Dr. St. John. The question I wanted to ask, you said that children usually get certain immunization shots at certain times during their childhood, and they're supposed to speak at least 20 words at a year old. But yet you're saying some children coming into primary school are not even speaking 5 words. So in the case of that, what is supposed to happen or what should be happening?
Can you hear me?
Yes.
Sure, okay. It's never too late. We have basic developmental milestones, and in fact, these children need to be referred through the system, which is slow, I must tell you. We do not have enough resources for our children. We will never have enough. We're a poor developing country. But we should utilize our resources as best we can. This particular child, having reached 18 months and maximum at 2 years, should have been referred through the clinic. They go to the polyclinics. They're seen for immunizations. Now, we have a bit of a shortcoming in that. The last immunization is at 18 months. So they're not seen at the polyclinic unless they're ill between 18 months and 4.5 when they need to have another immunization. So it's then left to the parent or the care provider or the nursery setting to advise that they need to be taken to the clinic, because that's where the majority of people go, or if affordable, to a pediatrician, to be referred to the Children's Development Center for assessment, because hearing is done at day 1 in the QEH. Every child now would get hearing, 99.9% for a number of years. They will get hearing tests. So if it was normal, it's unlikely that they have a hearing loss. But expressive speech disorders is not uncommon, and it's increased by observation. So they need, like yesterday, to be referred to the Children's Development Center.
Last one, pertaining to the same question. When you actually do sending information, sometimes it takes so long. As you said, we don't have enough, I guess, people in place, but that is one of the big issues as well. Because if you refer a child at 4.5 years or 4 years, it should not be waiting to 7 or 8 for someone to see that child or come and see that child, because then it's not going to help that child at all. So I'm just trying to figure out how you can work with the ministry and maybe Erdiston and see how we can get that done, because we keep saying we don't want to leave anyone behind, but we're doing a lot of that because of these same situations.
I agree with you. The complaints are chronic. We will never have enough resources, but I believe that where there is a will, there is a way. So if the child is referred to the A.C. Graham Center, which is the name of the center, oftentimes it can be, or it was, until recently, 2 years, to be seen by the developmental pediatrician and one speech therapist. Now, we cannot really service the island with one there. However, there are private speech therapists, and I know that an effort is being made to improve the resources. It's money and positions. So I think public pressure has to come to bear. Advocacy is important. If you do not advocate and agitate, you will not get improvements.
All right. Thank you.
Thank you.
Good morning. First of all, I want to say thank you once again, Mr. Payne and Ms. St. John, for being willing to come and share these thoughts with us. My question is directed more towards Mr. Payne. My question is about children when it comes to health and snacks. One thing I've noticed, I have a child that goes to West Terrace, and outside of the school facilities, typically there's tons of vendors that are all kind of surrounding the place with sugar, donuts, snacks, and it's easy. And of course, kids desire it. They run outside. They're happy to get it. And so I guess my question is, I'm wondering, well, it might be a two-part question. One is if there's any way to promote healthy eating outside of the facilities. And also, my question is, too, if some of these families, I don't know if there's been enough research to show that if a lot of these families run after these kind of snacks because it's cheaper or because they aren't educated enough. I know a lot of it starts at home as well. I'm just wondering if there's ways to even help maybe inform the families, or if it might be a money resource thing of how to help even the families with that. But I know right now I just see it all in front of them when they come out of school.
Thanks for your question. I think it's a very important question as well, too. I think when the school nutrition policy was conceptualized, it was conceptualized to kind of address these specific issues in terms of improving the school food environment. And there are several components to the school nutrition policy. I think vending continues to challenge both the Ministry of Health and Wellness, the Ministry of Education, Technology and Vocational Training, and it also challenges the advocates. You know, I think we have collaborated to educate vendors, to educate parents, to educate teachers, guardians, etc. But it really comes down, I think the key things that we can actually control, one, parents, guardians, teachers, modeling healthy behaviors, and that's key. At this current juncture, it's proving extremely difficult to kind of manage the outside of the school food environment. So I think it's key to continue to work within the school to kind of sanitize or control what is actually served within the school environment. But again, some key things we need to remember. One is parents and teachers, guardians, auxiliary staff practice or model healthy behaviors. And as much as you can, we need to continue to educate the children as it relates to healthy foods and what foods aren't healthy. And I think in time, we will see a greater shift.
Gotcha. And just curious, do you know if it might be with families, any issue in regards to money concerns or anything like that, or if it might just more of an education thing, or not really sure?
I think there's several factors into play. One would be taste preference. I think that's key. If these foods are introduced at a very early age, and it may not be that parents or guardians aren't educated, but again, these foods are marketed towards children and parents and families, I think it makes making the healthy choice very difficult. And I think a key component of what the Ministry of Health is trying to do is trying to kind of prevent or at least reduce the exposure children and parents have to these ultra-processed foods and beverages.
Okay, thank you.
Thank you very much. One final question for this segment.
Okay, just one moment. To answer your question about monitoring
Dr. St.
outside,
John wants it.
there's a bending policy which was drafted and approved, but it has to be proclaimed. It's been almost 2 years now. It has not been proclaimed for vendors. And within that policy, it says you cannot vend within a certain number of meters of the schools. Most schools will have vendors inside, approved ones by the school, and then you see a whole set outside. So this will pertain to the ones outside, that within so many meters of the school, you cannot vend unless you are vending what's classified as permitted snacks and drinks. Sorry, okay.
Good morning. My question is for Dr. St. John. As it relates to rashes, you mentioned hand, foot, and mouth. You mentioned contact dermatitis. My question is, I did not see things like ringworm or impetigo on the list. Could you explain to us what's the difference between a ringworm and an impetigo? I'm asking this for a nursery setting.
Sure, good question. I couldn't do a comprehensive list. I just mentioned a number of frequently seen conditions, but the ringworm is a fungus which burrows under the skin like circles. It's a ring and it's a worm type burrowing around, and that is contagious, so they have to be out of school for a period of time with that and on treatment. And then impetigo is a bacteria on the skin which oozes, and in fact a number of the insect bites, when they scratch and they become infected, they get impetigo. So that also treated with antibiotics and out of school until medically fit to return. Thank you.
Thank you very much, presenters. Mr. Payne, Professor St. John, thank you, participants. Thank you for your questions. That brings us to the end of this segment. Let us move smoothly along into the next segment, which will focus on development, another exciting area. Childhood is not a race to see how quickly a child can read, write, and count. Childhood is a small window of time to learn and develop at the pace which is right for each individual child. Author unknown, and with those words, let me present to you Mrs. Shelley Boyce, Principal, Maria Holden Nursery School, Sharon. She will be our next presenter. A very experienced educator, having started her career in 1976. Mrs. Boyce is currently the principal of Maria Holden Nursery School and a former principal of St. Stephen's and St. Boniface Nursery Schools. Mrs. Boyce received her training at Hurdiston Teachers Training College, the University of the West Indies, Mona, Jamaica, and the University of Illinois in the USA. She has the distinction of being the inaugural Teacher of the Year, 2003, and the privilege of being the first principal with experience of spearheading the opening of 2 government nursery schools in Barbados, these being St. Boniface Nursery School in 2006 and the Maria Holden Nursery School, Sharon, in 2011. Mrs. Boyce was co-chair of the Second Caribbean Conference on Early Childhood Education held in Barbados in 1997. She has facilitated several training programs for teachers and parents hosted by the Ministry of Education, Parados, and UNICEF. Through these programs, she has touched the lives of educators and NGOs in Jamaica, Grenada, Antigua, Guyana, and Guyana in particular. Mrs. Boyce is passionate about early childhood, and you're going to see that passion demonstrated today, and pre-primary education, and has appeared on many television and radio programs, as well as in the print media, to promote best practices in this sector. Mrs. Boyce believes that all children, when given equal opportunity, have the potential to achieve great things and contribute in significant ways to the future development of their country. Please join with me as we welcome Mrs. Boyce to the podium for her presentation, Stimulation in the Early Years.
Good morning, ladies and gentlemen, and thank you for your kind words. Dr. Morris, I am extremely happy to be here today, especially when I see so many persons that I have taught at school. And may I say, I am so proud of Mrs. Gail Carter, who would have been one of my students when I commenced the service in 1976. She would have been at Hinesbury Primary. So you need to give her some kudos and claps for that. I have always been told by my mother that teaching is a noble profession. And as I prepare to retire, this is really hitting home when I see my students excelling at the craft of teaching and in other fields. So teachers, the young ones who are here that I do not recognize, you stick to it. It is still the best and noblest profession. Today, I am very happy to speak on the topic, stimulation in the early years. And before I begin, I want you to focus on the slides, because I want us to talk a little bit about these 3 slides.
We have to listen. We have to listen.
See what the children are doing. This is the second one. Something is stuck. Miss Winter is controlling her.
Very nice. So we have to listen. We have to listen for when you have to.
Have you ever done that in your school? Bring torchlights in with the children? It's a great experience. And this morning we're talking about experiences to stimulate children. We're going to the second slide. This happened when we were at home in COVID times. We had such a lovely experience with parents really understanding what to do to keep children stimulated and learning. Now look, this is this little boy, and he had his assignment to make I don't know, maybe you can tell me what he's making. He has, what is he making there? It's no cake he's making. He's just making some cookies. Some cookies. And somewhere on the table, the teacher told him that it was his assignment to put 6 chocolate chips. I don't know if Mr. Bryan is going to lash me for that, but he had to put 6 chocolate chips in his cookies. The others had other quantities to put in their particular mix. Now, this is real life teaching. This is authentic teaching. This is teaching through the senses, and the children will never forget this lesson. So this is what I want to bring to you this morning. Authentic, real life, sensory learning. And when all the senses are involved, or most of the senses are involved in your teaching, the better the child will learn, the better the attention he will give, and the longer he will remember. So all of you teachers, when you are handling and dealing with children, get all the senses involved, not only visual and auditory, because you're talking, they're looking at you, they're looking at a board, or they're looking at a book. But what about the others? Tactile, taste, and so on. Let's go to the next slide. Here comes the egg. Notice how this child at 3 is handling the, look, his grip is good. For those who, look, the essence is going in. Here comes the spoon. There's a sequence here. And for those persons who teach in the lower juniors, this is an expository composition at its best. So those teachers who can do this in the class, there's no reason why you can't do this in your classroom, including making pizza, the healthy one, and asking the children to go step by step. First we add, next we do, finally. This is teaching at its best. The more senses that are involved in the teaching, the better the children will learn, the longer they will remember. And for the last slide. Ready, go put it all one time, all dancing, all, quick, all together, quick, all dancing, go put it all. Yay! Good. Thank you so much. That is a science experiment, also done during COVID at home. That child showed so much excitement with a Coca-Cola. I cannot help, Mr. Payne, but the experiment called for a fizzy drink and the fizzy tablets, and therefore, if you know Coca-Cola, there's anything that has the fizz like a Coca-Cola. So he put his tablets in the drink to see the reaction. And the bubbling didn't only come from the Coca-Cola, it also came from him. And what did he do? How was he stimulated? What did he do when the experiment was successful? His mother's in the background also excited. This is what education is about. Your children should be excited like this, not only 3 and 4-year-old children. All children in schools from, well, we're in primary, from 3 years old in the nursery right through to that 11-year-old child should be excited about coming to school and want to come to school. And these 3 introductory activities which I highlighted to you are very stimulating for a child's growth and development. Now, from the outset, I'm talking about sensory learning. Multisensory, sometimes you see in text, multisensory learning. And when you employ the senses, because we learn through our senses. What happens at school, though, because I think about a lot of circumstances, we do not do taste, the taste, and the touch. The taste and the touch. But in one of the experiments here, the making of the cookies, I think every single sense was used. Let's think about it. His hands were in the dough, and he was kneading the dough. From that mixture, I am sure he could smell something going on there, especially with that essence. He is hearing what? His mother's instructions, and a teacher has to give instructions. So she's at home training him to listen, but listening through an authentic, real-life, enjoyable activity. And this is at home. And then what? He is seeing the results. And eventually, when he makes his little separations and he counts his mathematics and he's doing his language and extending his vocabulary, it's an integrated approach. And this is what we should do as teachers of young children, of children in the lower juniors, of children in the upper juniors. It is integration because it makes sense to the children. When I was at secondary school, I did what we call the binary system. A lot of ones and zeros. I never understood the thing. I could get it right because I used a formula. But I never understood what it was about until later in life. I understood it was the language of the computer. We as teachers need to make sense of our learning, sense of the activities for children. They will like what they're doing when they understand why they're doing the thing. So that is a challenge I want to send out to you. Make them understand why they are learning what they are learning, why they are writing the little scripts, why they are drawing, and why they're listening to music, dancing, running, jumping. I say that because the parents of nursery children like to ask them the question, what did you do today? Don't you encounter that? And what do the children say? We play. We ain't do work. We didn't do work. We play. And another thing is that I have encountered recently, because I like singing, I like dancing, I like that. I want you to visit the tables there, because we buy all these things to get the children happy. Color and costumes and so on, used to teach the children. It isn't only you, although you might be good looking. It takes a bit more than your good looks to stimulate those children. But a parent told me, well, this is a singing school you got, Mrs. Boyce. Well, all my sons say, he sing a song, he sings songs. But that song is rhythm. It wakes up the left and right brain. It is vocabulary. And it teaches rhyming and literacy. So what we need to do then is to also educate parents in the nursery school, in the lower juniors, in the infants A and infants B, about the value of these stimulating activities. we want to ask the question today, what is stimulation? Now I have given you a lot of examples of the definition for stimulation. And there are agencies such as the UNICEF, bless their souls. I've worked with them and they've facilitated early childhood education throughout the years in Barbados. UNICEF, the Caribbean Development Bank, the Caribbean Community, the OAS. These are organizations, international organizations, regional organizations that support early childhood. And they all agree that stimulation is provided by participation in activities. Notice that you got to participate. That means you have to do something. Children learn best by doing. So the child has to do something. And if the child is doing something, where is the teacher? The teacher is doing the thing as well. So the teacher is participating with the child. We are all active in the classroom, active learners. The young children are being guided, facilitated on the side by the teacher and the caregiver, because it happens in daycare. Child care works very closely with the nursery schools. We do the same thing. We are all into child development. And if we want to do our job properly, we need to look at the research and the studies that guide us to do our jobs. So the caregivers guide the children, the teachers guide the children, and of course the parents. So UNICEF and the Caribbean Community, in the Caribbean Development Bank and the OAS and so on, all agree. Keywords: participation, activities performed by the young child, and supported by the teachers and the parents. Pediatricians have a say as well. They describe stimulation in the early years as a process of providing young children with a range of experiences and interactions. What is this range of experiences? When a child comes to school, what range of experience do you have for them? It's a range of experiences. What are they coming to you to do? What do they do? I'm talking about experiences. What do you provide them with? A nice building. I have a very beautiful building, by the way. Yes. That environment is the second teacher in the classroom. It is you as the individual, and the environment sets the tone for teaching and stimulating a child. And you don't have to spend a whole lot of money. You can make your environment beautiful and welcoming to children. But it's a range of experiences that they need to have. Don't we take children on tours? Do we still do that? Oh, good. Do you take the 3 and the 4-year-olds on tours? Good. Oh, Miss Dr. Morris, we are on the ball. What does that do? The range of experiences, what does that do? That promotes cognitive, emotional, social, and physical development. And we cannot teach without our first-hand experiences. A child should not come to school and sit at a desk from 9 o'clock to 3 o'clock. All literature says, get the children outdoors. You see this beautiful sun we have? That is healthy for the young child. When I attended St. Mary's Infant School, you know St. Mary's Infant School? I am from town, so I went to St. Mary's and Westbury. We had something called Nature Walk. What I'm bringing to you is real, authentic experiences backed with some research from texts and the expert. But we know what we are doing here. We don't have to be like the Americans or the British or anything. We have had a solid foundation in education, and we need to continue know what we are doing and continue to do what we know is right. I have never been stopped by any officer in the ministry, including Dr. Morris, from experimenting with the young children, taking children on the Atlantis submarine years ago when it first came. And when everybody was so frightened, oh there, we have to go to this thing. Now everybody wants to go to the submarine. Taking children to the light airplane club. Have you ever put children in that small airplane and let them hear that engine roar and so on? Have you taken children overseas to a market in Grenada? I love Grenada. There's our Grenadian counterpart. I am talking about integrating your activities and making it real for the children, that they learn better, they pay more attention, they are more disciplined, and they remember longer. So when I taught at the St. Albans Infant School, great at projects, great at the project approach. And that is what we are advocating yet again. We're coming full circle. Play-based learning and the project approach. We did a project with UNICEF. I don't know if our UNICEF person remembers that. St. Albans won that competition. Oh, Miss Griffith, you were there? She was there under the great Esme Bascom. And we took the money. You know what we did with the money? We went to Grenada. And we took parents with us. Because our project was going to the market. And we were going to Grenada to a market that is unlike any market in Barbados, to show the children the Caribbean, to let them hear a different accent, to let them see crabs running around in the market. I've never seen that before, and I remember to this day. But first-hand, authentic, real-life experiences. The days of traveling with children might be a bit more complicated. I don't know, Dr. Morris and the ministry would tell us. But I remembered the secondary schools leaving in the morning, like 6 o'clock, and going to like Guadeloupe and coming back in the evening because they were going on a geography tour to the Pitch Lake, to the aqueducts in Jamaica. I remember going to those places as a school child. We need to get back there. First-hand experiences. Why do you think I'm so fired up at my age? I had a wonderful childhood and a wonderful school experience because my teachers made sense of what I was doing. Teachers, that's your challenge. Overall, the medical profession and the educators promote a holistic approach to stimulation. You're not only going to stimulate the academic side of you, you're going to stimulate the social side, you're going to stimulate emotional, you're going to stimulate the children, because at this stage, it gives profound, lifelong health and development. When you sit in a classroom, if we're going to be developing social and emotional skills, what is the design of your classroom? When I walk into classrooms, it tells me the philosophy of the teacher. As an examiner of teachers with a very keen eye, I can tell you what you believe in. I would advocate, I will challenge you. A lot of challenges today. If you want your children to develop language, to be socially adept, you must arrange your classrooms in semicircles and circles. You cannot all face a chalkboard. From 3 o'clock, from 9 o'clock to 3 o'clock, every day of the week. The child will only know the back head of the child in front of it. So when we're talking about stimulation, we're talking about social development, we're talking about emotional competencies, it has to do with your classroom arrangement. Circles, everybody is looking at each other. Everybody gets to know each other. Everybody's talking, developing conversations, knowing social skills and social graces. So I challenge you to look at that. Are you afraid to push around the chairs in your class? Are you afraid to push them to the side and form groups in chairs? Somebody will stop you. I challenge you, just look at that. Because if we are going forward with reform, we have to look at how we teach and the environment in which we teach, promoting social skills, emotional competencies, academic competencies, etc. The Ministry of Education also promote for us and encourage us from birth through 8 to create nurturing environments for the children, learning through play, exploration, and structured activities. We didn't say we wouldn't structure activities, but the children learn best through play as well. So play and structured activities. Can young children be stimulated before birth? Research has shown that before birth and in the womb, children respond to the mother's voice, touch, light, and music. There's a piece of music we use at school all the time. When that is played at quiet time, it does something to the children. Do you play music at quiet time in your school? Please, please continue. And what I ask them is which instrument is being played. It is holistic, and this is all about integration. In brain development as well, we must know that by 5 years old, 90% of a child's brain is formed, is in place. His ability to speak by 5, movement, all of those things are in mood, emotions are all in place. And after that, only 10% then of the brain after 5. This is a very critical period for language acquisition. I have recently started Spanish in my school. It's an experiment. I like to experiment. If you teach languages early, before secondary school, and I love languages, the children will respond quicker because the brain is very plastic at that time. You can try. You don't have to wait to class 1. You don't have to wait to influence. Try some Spanish in the schools. I remembered my nephew used to do Chinese at St. Stephen's. We have St. Stephen's persons here. They used to do Chinese at St. Stephen's. So we can try at this critical period to learn different languages as well. We want to say that positive actions, positive interactions with caregivers and teachers in stimulating environments can significantly enhance cognitive and emotional growth. We do not want the children bothered and fretful and so on. We spend too much time untangling that. We need calm, focused environments. What's ever happening in the home being the child's first school, must continue in the school. And where the home lacks the activity, we in the school will pick up the slack. A loving, nurturing environment filled with laughter and support. What activities do we do at home? We read aloud. You do bedtime stories. Put away the devices. Have device-free days and device-free some periods. Let the children handle the book. Turn the pages. We still do that. Give the children chores. Let them paint, run, stamp in the mud. Maybe you wouldn't like that. The parents wouldn't like the mud thing. But they like to stamp in the mud, run in the rain. I remembered one time at St. James Primary. I taught all over the place. St. James Primary, the rain came down. And I told them, come quick, put on the raincoat. Let's go outside. Raincoats on, and we outside in the rain, running up and down. Well, I got caught because the principal was in the office. So I gathered them quickly and got back into my class, but they had to draw and write and produce vocabulary for that activity. It is just a way of bringing life to the children. Outside exploration is another stimulating activity. Arts and crafts and the performing arts. And you look around, you see I've brought the bells. These are tuned bells here on that table. And there are videos and so on that can teach you in the schools and the children how to play those bells. It is not a difficult thing to do. So I want you to update and enrich your classes. Get the music going. Get the singing going. I'm sure the children sing and they dance. But you can buy these bells and get the video. We learn so much from the internet now. We can get that going. And of course, dramatization and storytelling. Reading is important. Look at what this little girl has done with her sets. Mathematics. But they must be done in a real world. What is she doing? The teacher just drew a circle. She didn't wait to get a fancy anything with some chalk. Got the covers and there. And she is doing her numbers. The little child is the links for fine motor skill development. All these are stimulating activities. Child care and the nursery school is where they will come after they have left the home. Here we see children working with tablets and so on. Here the child is to match the fruit to the label. What fruit is she trying to find? Well, she would have been taught that before. What fruit does she have in her hand? Can you see so far? A pomegranate. We have pomegranates at the school. And may I say to Mr. Bryan that we have a small orchard at the school that we planted. And we have pomegranates, sea grapes, carambola, green thing. They came from soil, and the trees are flourishing, including a custard apple. Children don't eat the pomegranate. Why? The seeds and the texture. They don't like that texture, but we puree the thing and let them have a taste. It is all about the senses. But you know, before you do anything like that, ladies and gentlemen, let me warn you, you got to ask a parent's permission. Because you do not know, sometimes you think you're doing a great thing, but the parents might say no because the child might have the allergies to that. Story time, art and craft, music and movement, physical education are all stimulating activities in the daycare and the nursery school. Puppetry, while at Erdeston, Dr. Megan Goodrich, I'm sure for those who are in this age group will remember her. She loved puppetry. She loved puppetry. I was taught how to use puppets for the teaching of young children, and they're used successfully in social and emotional learning. There are puppets over here. All of these things came from Barbados. I purchased most of these things from Laurie Dash and Deanna Dash. They're all out there. The use of the center of interest approach, which is a John Dewey approach, children learning through discovery, children learning by first-hand experiences, children dressing up and speaking the, what are you? Those are
We're going to pour the vinegar in the volcano. Yeah, volcano. And we're going to look to see what happens. Step back a bit.
This is after the eruption of Soufrière.
Pour the vinegar in the volcano, and we're going to look to see what happens. You have to tell Miss Nichols what happens. Put your hand behind your back. Hannah, hands off the table. Hand behind your back. You have to look to see what happens. You ready?
Ready.
Woo! Step back.
Big eruption.
It erupted. What happened? It erupted. The lava is coming out. Let's see if it's going to erupt some more.
Me too.
They love to scream, don't they? Eruption.
Good job. Let's see if it has any more eruption. Good job. Step back. Oh, that's the lava. The lava is flowing off of the wall.
In the red zone.
Off the table. The volcano erupted where? In where? What island? Saint Vincent. What came out of the volcano? Lava and
Come off the tree.
and ash. Where did the ash go? To Barbados. How did the ash go to Barbados?
I was given a cue that I have 5 more minutes, but I want to just let you know that in nurse school you can have 4-H as well. I'm talking to you about stimulating activities. We are dealing with real world, authentic things. We are lifting this information from the book and we are doing the thing. Young children learn best by doing. Young children learn best when all the senses are involved. Parents and parent projects, kite flying, look. I'm sure you fly kites at school as well, because we all do the kite flying. It's a wonderful experience. It brings out the dads. All of the national events, the independence, the African awareness, and the teachers try to sing. And they sing calypsos as well. Do you sing calypsos in your school? Yeah, the beach is our beach. Dramatization at Christmas. Children love to dress up, and the language is beautiful. Self-esteem building, self-concept. We are taking the words off the page, and we are doing the thing to stimulate our children. Look at this little one. She's trying her best. And of course, our stakeholders visit the schools. We never forget our stakeholders. These are the fire service, persons from the fire service. And also, here is our guest readers. Do you recognize this gentleman here? Our guest readers come to school to read for the children. We have a lovely library. These mats are sold at beauty supplies. You can get the mats and put them down in your car. Push down the furniture, put down the mat. And they're teaching mats. Your picture discussion, these mats are just beautiful. This is my nephew when he was with me at school. He's now 13 at Combermere, and he is there with Christopher Holder, who comes to read for the children. When he is in Barbados, and he will come to read for. So adopt a guest reader program. Sometimes they get a little tired hearing our voices. Let them hear other voices and other accents, because we are producing global citizens. We're not teaching children only for Barbados. So they need to get to hear other people, men and women. Even the Prime Minister, the children went to meet at the opening of the Welch's Play Park. I remembered around Christmas time. And you give them opportunities to engage in conversations with persons, and there we are. And in closing, all of this builds intellect, it builds character, but nothing like saying your affirmations every morning. Do you say affirmations as well? We have to say those affirmations for our young children. Here are the affirmations that the children at Maria Holder Sharon would repeat every morning. And who is repeating? Am I hearing her voice? I am beautiful, I am happy, I am intelligent, I am ready to learn, I am special, I am curious. And the curiosity builds on science. The curiosity brings science. This little one, we recorded her. She volunteered to say her affirmations. She likes to read. And this is Jamie.
I am curious. I am positive. I am beautiful. I am intelligent. I am ready to learn. I am special. I am happy.
This is Jamie Duglin, and her mother gave permission, Dr. Morris. We can't show children's images and so on without the parents' permission. She said she was intelligent. If you hear that every day for 38 weeks in school, what is that going to do for you? It's going to put it out there in the universe, and you are intelligent and you are ready to learn. And there's a posture for listening and a posture for learning. Don't you teach your children the posture for listening? They can't talk when I'm talking. You are not speaking and I'm speaking. So all of these things that we take for granted are very critical. Simulation in the early years is critical because it supports the overall development of the child's brains and bodies. Activities and interactions and experiences help to strengthen neurological connections that promote learning. Stimulation in the early years foster cognitive, social, emotional, and the physical development, whole child development, helping children to develop essential skills. With that, I thank you for your attention.
Thank you very much, Mrs. Boyce. And we're going to move into the next presentation in this segment of today's schedule, which will focus on social and emotional learning. And I know on your schedule you would see the name Mr. Tony Olton written, but today we are happy to have with us Canon Reverend Dr. Sonia Hines. She will be representing the Potter Center. Dr. Hines is the rector of St. Leonard's Anglican Church, and I know that she's currently functioning as chairman of the Board of Management of St. Leonard's Boys Schools. Please, let's welcome her as she presents on the topic social and emotional learning.
Good afternoon, I almost say sisters and brothers in Christ, but I think I can do that here, right? And it's really good to be here, and I want to thank the indulgence of the planners for allowing me to substitute for Tony Olton. I can't say that I would be able to be provide as much as I would want to, since I had very short notice, but I taught for a while. So I felt really comfortable listening and being part of this space with you. I taught, and some of you might remember, the secondary vocational centers. And those were the centers that had the children that left at 14 years. And we kept them for 2 years and taught them some basic. So it's good to be here. I know you, like me, are hungry. And I want to invite you to stand. And stretch. Yes, stretch. Right up, don't feel shy. You were sitting for a long time. And then I invite you to sit. It's good to be part of this symposium, as I mentioned. I have no children of my own, and my time of teaching was short as I moved into social work, really, spending just over 9 years at the government industrial school as a supervisor. And then, of course, coming into the ordained ministry. But the work in the short time I spent teaching included the preliminary in-service program, where I got a certificate, I think it was then, and met Mrs. Greenwich. But the opportunity, I think, to teach comes when I preach. And the teaching and preaching then makes a lot of sense to me, particularly in the context of social and emotional learning. Big one is, I was asked to spend 20 minutes with you, and beginning a little later than planned, but I want to ask you to do a short meditation. I want you to sit back comfortably in your chair. And if you're comfortable closing your eyes, you may. But I want to ask you to get in touch with what emotions you are experiencing now. Apart from the one that's close to hunger. Well, just spend some time, a couple of seconds. What are you feeling now? Thank you. Would anyone like to share what emotions you are having now? Gratitude, yes, thank you. Gratitude. Excitement, okay, yes, thank you. Yes, any others? Oh, the faster you speak, the quicker we get lunch. Loving in our hearts for one another, very good, thank you. Especially when Grenada was mentioned. Yes, yes. And that is good. And perhaps those are the feelings that are similar to what you felt when you came this morning. Because one of the things about emotions is that they come and go. So that sometimes we might think that when we are angry, that we will remain angry for a long time. But in truth and in fact, angers, like all emotions, come and go. Some researchers say that they last for only 3 to 6 seconds. So you can be feeling a lot of emotions in 1 minute, in an hour. And emotions are not to be afraid of. They are really data, giving messages. They're data they have language all on their own. The challenge is that we have not been taught how to recognize, use, understand, or manage our emotions. And that is what emotional intelligence is all about. Emotional intelligence helps us to recognize that emotions drive people. So that when we are in a certain space emotionally, we have to be aware of that. And I will speak to the 3, what some call pursuits of emotional intelligence. But a definition that I would give of social and emotional learning, which is what I'm to speak to you about, is that it is socially learning and emotional learning is the process by which children and adults acquire the skills of emotional intelligence, an integral part of education and human development. And not just acquiring the knowledge, but applying the knowledge, the skills, and the attitudes to develop healthy identities, manage emotions, and achieve personal and collective goals, to feel and show empathy for others, establish and maintain supportive relationships, and make responsible and caring decisions. And the thing is, if you as teacher, or even parent, or child giver, child taker, child caregiver, yes, thank you, are not emotionally intelligent, you're not going to be able to have children in your classes that are emotionally intelligent. Because one of the main things about emotional intelligence is self-awareness. You have to know where you are before you do anything else. Self-awareness is very important. Some call it know self, something about tuning in to yourself. How can you tune into yourself? If you wanted to zero in on where you are and become aware of yourself, how do you think you can do that? Yes? Sorry? Practice mindfulness, yes. That's one way that many people do that. Mindfulness, yes. Yes? I didn't hear the first part. Just the first part. Oh, SWOT analysis, okay. Weaknesses, opportunities, and threats, okay. Implement. You went a little further than I had planned because I was thinking more of exercises like mindfulness or just becoming quiet, but that is important as well. Because what you want to have in front of you as terms of children is an opportunity for them to know that you are with them emotionally. Yes, you have to teach them math and English and all the other things, but their emotions are important. I have the privilege of being the pastor, priest at St. Leonard's, and every Tuesday, perhaps when Dr. Boyce was going to school at Westbury, it was Wednesdays. The school children, they come over to the church for church service. And this month, I deliberately used the Child Care Board's theme. And I deliberately chose areas for them to look out for with child sexual abuse, telling them the importance of, if they feel uncomfortable when they're being touched, to let somebody know that. That if anybody tells them to keep secrets, to let somebody know that don't keep secrets like that. And things like that. But I'd say all of that to say, but as I was talking to them about how to be safe and how to encourage others to be safe, because I want them to look out for each other too, there was something happening. You don't always get a whole school listening attentively, but it was clear that the statistics might be on the right track, that many of our children are sexually abused. The sad reality is that some of them are not believed by adults. But we have children that their emotions are in turmoil because when they're taught at school, nobody's paying attention to the emotions. They're only paying attention to that they're not doing the schoolwork. So once you zero in, or once we zero in as adults to our emotions and know where we are, and then we are able to pick up and help those children to also to be comfortable expressing their emotions. And they will need to express those emotions if they are to be helped. Another thing we have to do with emotional and social learning is and it's all tied up with self-awareness, is what some call choosing self. That is managing ourselves, taking conscious decisions about our feelings. So if you are here in this room and you need to go to the bathroom, you don't have to wait, because you have to take a consideration, or a topic is going on that is just making you, triggering you for some reason. Then you are responsible for your own feelings and to deal with that. That is emotional and social learning in action. So emotions are important, becoming aware of what you're feeling, tuning into that through mindfulness, for example. But you also then have to take some responsibility for your own feelings and what you would do about it. And then finally, what do you do in terms of the giving? It's called give self. What do I want to do in my life? Now, that gives it more, that moves it from not just being about self, but helping that, recognizing that self is part of community. Is it Desmond Tutu or somebody that say, I am because we are? No, I am because we are. Because I am because you are. Which means that this whole thing about us living in community is important. And if members in our district or our school, workplace, church, communities are going through challenges, it also means that we have to be in tune in ways to help them. So social emotional learning is a very important aspect of how you function as teachers. And it helps you to vision then children who are emotionally intelligent in your class. I was interested to listen to the presentation on stimulation, because what is calling for is for teachers to get children stimulated. And to me, as I listened, to get the children stimulated, it means that you too must be stimulated. That is, you must be in tune with what it is that stimulates you. So if you don't like rain water, you're not going to take the children outside to have a good opportunity to be in the rain. So what does that mean for you as a teacher? I lived and served in St. Lucia for just a year and a half, not Grenada, unfortunately. But one of the things I noticed with one of the two of the primary school teachers is that they wore high heels. but they wore high heels to school, but once they get in the classroom, they took off the high heels. And I found that very interesting because what the message I was getting is that they recognize that the teacher, I can't remember how Dr. Boyce put it, but the teacher represented something as part of the learning process. And therefore, to get children stimulated or even to know how they feel emotionally is that you almost have to be with them physically and not only just, and figuratively too, but they took the time to come down to the level of the children when they got into the classroom. And I am sure that some of your teachers do that as well. I'm now seeing some former Raspberry teachers here. So we have to put emotional and social learning into action, even when we are hungry, to see how important it is for you as teachers to be recognized that you are the leader in the classroom and that leaders influence. I went to Hinesbury Primary. Anybody teaching at Hinesbury now? Oh, good. One of the best primary schools in Barbados. And had some wonderful opportunities. I will also remember that Earlston College at that time signed a lady who called Miss Forbes. I'm trying to remember her first name, but this is all back in the 60s. Although she taught for only 4 weeks because it was part of the program at Earlston, I remember us crying when she was leaving. And I remember crying because I think she stimulated us, even though I didn't put it in language like that at that time, that she was somehow able, she's now, any Moravians here? Yeah. I think she's Mount Tabor. But she was able to stimulate us in such a way that we were able to gauge that what we were feeling emotionally, and this is only on reflection, that she was able to identify with. That it was okay to play in the mud and do the activities, but she was touching us at a deeper level. And we can't touch children or anybody at a deeper level if we are not emotionally aware, if we are not self-aware, if we are not able to recognize that our emotions are real, and therefore we have to own them and be able to learn from them and to be able to then bring people into a deeper space with them, particularly children. So practice, I would say, is self-awareness. Mindfulness is one way that we can do it. I would say practice how to motivate after you have come to some understanding of self-awareness, and that has helped you to see priorities that you need to put in place, particularly with children, that you might have to come in with one lesson plan, but then because of the emotional state of the classroom, then you have to change that. So it helps you to build on something very important that I will come to the conclusion with, empathy. If you do not empathize with the children, and you can only empathize if you are self-aware. If you cannot empathize, and one big thing about empathizing is listening. Not just listening to the words coming out of the child's mouth, but listening to the child's heart. I asked one of the students of Westbury some time ago, we were teaching about Jesus and his disciples, and I can't remember which story in the Bible. And he was telling me that he think the disciples were evil. And I tried to explain, they're following the good man, and maybe the good man want them to do good things too. And so what do you think? And he kept saying they were evil. And that thing worried me a bit, because that child was telling me something that I didn't quite understand. And one friend was suggested that the image of men, the whole question about men might have been something that triggered something for that child that was answering that way. So in listening to children, we have to be very mindful that we not only the words and then we judging them on the words, but they're telling us something else. So I have a diploma in assaulted women and children's counselor and advocate that I did while I lived in Toronto at George Brown College. And one of the things we do as persons who will be counselors and advocates for children and women who are survivors of abuse is that with children, they act out differently. So you will have a child that's suddenly behavior change in the classroom. And that will give you a hint if you are not too quick to judge in a negative way, that something emotionally is happening with that child. So if that child is accustomed to being talkative, and then suddenly become very withdrawn, or that child used to dress fairly neatly, and then you get into a situation now they just seem to be putting on the clothes, or that child used to be early, and now comes late, or vice versa. Those are the signs that helps you to get into seeing what's happening emotionally with this child that is supposed to be learning. Because you know what? That child can learn what you're teaching in terms of the academic side of things because of what is going on emotionally. So that's why it is important for you and I to be in touch with our emotions and know that we need to practice empathy, that we need to understand body language, that we need to have good listening skills, that we need to be at ease with ourselves, and those sort of things that helps you and me to grow and to be able to get stronger, so recognizing how important it is. So I will conclude before Dr. Morris gets here to tell you that the social and emotional learning has a very positive impact on a wide range of outcomes, including academic performance, healthy relationships, mental wellness, and so on. So it's not just seeing the child as a child that would do well at the common entrance. And this is, you know this, I'm just reminding you. But a child that is also in need of some emotional care and some care that reminds them that they are more than just physical, but they are spiritual. I thank you.
We thank you, Dr. Hines, and I invite you to join Mrs. Boyce. The next presentation in this segment is entitled Literacy in the Early Years. And here to present to us on this topic is Ms. Alison Maurice, Special Needs Tutor and Administrator, Literacy Assessment Diagnostic and Early Intervention Center, Erdiston Teachers Training College. Let's welcome her as we look forward to hearing her presentation on this important topic.
Good afternoon to everyone. The presenter just before lunch, I know that you are looking forward to the break, but I have 20 minutes and I want to engage you in a different perspective than what would have been presented so far that I would have seen. And my perspective is shaped on experiences I would have had, students I would have met, parents I would have engaged with. And I believe it's critical for you as early childhood educators or practitioners to stay with me and to ask questions and to engage as we think more about this word, corner. All right? So keep the word corner in the corner. We're going to revisit it as we go through this entire presentation. We're going to talk a little bit today about the issue of equal access for all children. We're going to talk about some of the disparities that exist as it relates to access to books and literacy resources. And we're going to explore a unique approach to promoting early literacy. But I want to ask the question, how did you come to know? I want you to think for a moment, how did you come to know? Interesting question. How far back can you go? What's your first memory of knowing? And I want to hear from you. I'll share mine. One of my first memories is sitting in my mommy's lap in our gallery, and she was singing, "How much is that doggy in the window?" And it would go, "Arf, arf, arf, the one with the," you know that one? So that's how far back I'm going. What about you? How far back can you go? How did you come to know? You're thinking. All right, we have a hand over here. Yes, please. You don't have to stand. It's okay. Mm-hmm.
Fat cat. A big fat cat was in the picture of the book, the Royal Reader, the premiere, whatever they call it. And he would say, "This is a cat." That was the reading. "It's a fat cat. It has a long tail. It has soft paws." My father was my first educator. I learned to read.
All right, we give thanks for Daddy. Nice, nice. Anybody else wants to share? How did you come to know? Yes, right in the back, please. You may need to use the mic.
Okay, my father was an educator, so I remember when he was on vacation, he was an avid reader. Those very small Western books, if anybody knows of those. He would have us reading, he would be reading next to us, and we would have to have a book. So for me, that's like, I could have been 3 or 4 or so. So that is a fond memory of mine.
Okay, we're hearing a lot about daddies. That's amazing. Love to hear it.
Hi. One memory I have, one of the earliest memories is me holding up my fingers, describing how old I was. Every time I had aunties or uncles ask me how old I was, I would always say, "I'm 3 years old." And I would say that all the time. Even after my 4th birthday, I kept on telling people, "I'm 3 years old." So that was a big memory for me.
Wonderful, and thank you for sharing. So I have some images. Perhaps you're not seeing them that well, but I do have some images projected. And over on this end are some characters. Now, I tell people I'm 27, so work with me as I develop that theory, all right? Sesame Street formed a huge part of my path to coming to know, all right? It was exciting. There were so many wonderful uses of language. B is for bubble, 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 bubble. Good. Oh my goodness. All the flashbacks, everybody's with me. And what was interesting about Sesame Street in my day, which was obviously just a few years ago, is that at the end of it, there were so many members of boards of education who sat in terms of the productions, on teams in terms of the production of the show. So you were seeing all of these credentialed individuals for whom, the entire production is based on their advice and perhaps based on best practices, all right? For some persons, some students you may teach, they may come to know in a salon, all right? We hear Beyonce, she talks a lot about her development being in her mommy's salon. We know salons are not always, the safest place for a child to be, but a working mother perhaps can't do any better sometimes, and her child has to be there with her. Right here is a picture of the public library in Oistins. I have fond memories of going there. It's not in function right now, but hopefully that sorts out itself. Bottom right, you may not be able to see it, but these are some old granddads slamming a drum, right? Usually done under the street light, yeah? And you have some hollering and shouting and slamming and everything. And you have little boys around, and they come to know in a different way, perhaps, than somebody who would have just been watching Sesame Street or who would have been visiting the library. In the middle are some of those readers. You would have referenced a few readers, but you know, we had all of these different stories that perhaps would have been on the shelves of your library. All of these experiences that we just shared combine to help develop literacy as you go on. Now, the concept of literacy continues to evolve, it continues to grow, and there are some new definitions that are out there. Back in the day, you may say reading, writing, arithmetic, and in Barbados, we tended to boast that we had a 100% literacy rate and all of those wonderful things. Well, I don't have the data, so I can't say not now. I'm very hopeful that we are pretty close. But the idea of literacy is being shaped by a lot of the advances that are being made in terms of technology. And literacy is so huge. It is an idea that you know how to read, you can use numbers, you can write, you have digital skills, you have media literacy, you have that skill set that is needed for you to be able to call yourself a true global citizen. And you also have those job-specific skills. So this means then that everybody in this space who perhaps deems themselves as a literate being should be able to rattle off for me what these symbols mean. So let's go. Who's going first? You gotta give me all. We ain't want pauses. I want it. So you know, like sight words, cat, right? I want you to. So we're going left to right. Face up. After hearing YouTube, I was hearing this. After Pinterest, I'm hearing All this is part of literacy, and these little ones in our spaces, they know quite a bit about these different platforms. They know how to upload content even better than myself. They know how to click like, they know how to follow. All of this is part of what we deem to be literacy. I want to go a step further. Remember that word that I showed you at the beginning? Corner. So we have our early childhood practitioners here, and early childhood, of course, stretches until age 8. So that means that we have persons in the space who should be able to tell me exactly what this is I have on the screen. What is this all about? So it's the word corner. Talk to me. What are we sounding out? Gotta be explicit. What are we sounding out? The sounds in the word corner. How many letters are in corner? How many sounds are in corner? How did we get to that? O and R. Why isn't this word sorner? Why isn't this word sorner? It's not. Why? And we know, what's the rule for the soft C? Bigger yourself. You got it. Excellent. This information just flowed from you, right? You had to go through a process of learning all of these things in order for you to be able to understand and analyze these particular steps that we just went through. Exactly. That's it. As an adult, but not as a child. So where I want to take you is a consideration that every child that you engage with may or may not, in the home space, have been exposed to these types of practices. And sometimes they're red flag. You may deem that they are lagging a bit, that they're moving a little slowy. But there's so many factors that can impact on literacy development. Corner is one of those words that we know to be multi-meaning words. Would you agree? It could be a noun. right? A place or angle where two or more sides or edges meet. It could be a verb. When you force somebody or an animal perhaps into a particular situation. So if you say corner to a bunch of students, a group of students, there's no guarantee that what you have here is what they understand and what they interpret. And sometimes what happens is it's all muddly and medley for our students. Now, apart from my esteemed colleague in the paint jacket who would have just gone through the idea of knowing the soft sound for C and the vowels that must come after C to get that sound, have you ever thought carefully about what happens to those boys and girls who leave you after nursery school, after age 8? Do you sit and think about what really become of these children? What happens with them after they leave you? They struggled all through. Do you know what life is like for them after? And can we have an honest conversation? Do you think about them? Sometimes you think about them and you wonder, how's it going? Most times. Sometimes she wonders. I've spent most of my teaching career at secondary schools in Barbados that cater to students who score between 0 and 30 in the Common Entrance exam. And many of these students have severe challenges with literacy. And the severe challenges with literacy seen by me at secondary school, yes, but would have been seen by the primary school teachers and perhaps would have been seen at the stage of nursery school. All right, I'm going to show you a clip. Hopefully you can hear it. Going to get some technical support here. All right, we're going to forge forward, but this is an adult learner, and he's basically giving his testimony. And I do have the words that he would have been saying. So he said, she will spell it for me, and I will write it. And if I go home now and try to spell December, it's like, I can't spell it. And I'd be trying and trying and trying. I want to explore the definition of corner in this situation as the verb. This adult would have been forced into a situation that is really hard for him to escape from. Adult learners who struggle with literacy tend to struggle in all areas of functioning. So when he was at secondary school, his teachers would have seen some challenges when he was at primary school and perhaps at early childhood, and nobody was able to provide the support that he would have needed. This particular video, we're forging forward, but this particular video also would have been useful in showing you some of the challenges that we also see in the space at secondary school. And so this is a first form student who was attempting to spell his last name, which was Williams. And as early childhood practitioners, you can take a peek, perhaps, and you can see that even in terms of the handwriting skills being displayed here, they're pretty immature or a bit behind, delayed for what we would expect a first form student to be displaying. Would you agree? Let's look at the W. We know that capital W is supposed to have those nice straight lines. Yeah? This is a real picture of a real family in real Barbados. This picture was taken during the pandemic. A student who would have been in Infants A at the time, and he spent most of his day sitting in this space trying to steal some Wi-Fi so that he could log on to his online classroom space. This is his corner. He's been cornered. He's found a space, but it's challenging for an Infants B child to escape this on his own. And so when I mentioned to you the perspective that I'm going to bring is a little bit different. We talk a lot about the facilities that we are making beautiful for boys and for girls in our early childhood spaces and age groups. But there are a few of our students that are really being left behind in our system. And my perspective is always about how can we reach these students who have been cornered. Most early childhood programs, as you would imagine, are center-based, and they look beautiful. You know, they have corners, literacy corners and spaces, and lots of little tools and technology that teachers use. But how can we set up a space, a safe space for a child like this? How can we now explore a corner? How can we meet as education practitioners and the family in order that we do not forget these boys and these girls? I want to introduce you to the Roving Caregivers Program. And the Roving Caregivers Program is a Caribbean model. Not sure if you're familiar with it. We tend to, excellent. Perfect, good, good. We tend to borrow a lot from models outside of our region. But what is unique about the Roving Caregivers Program is the focus on bringing services to the individuals who we have identified as being vulnerable. So we know that Tommy can't make it to school because mommy perhaps doesn't have money for bus fare, or there was just no money to give him lunch during the school day, so you stay at home. How can we cater to a student like this? Not sure if you're seeing, but the innovation starts with a conceptual advantage over the traditional modes. Like I mentioned, it brings the services to the recipient. It acknowledges the role of the parent as the child's first teacher. You would have heard that before. And it lessens the financial burden on families as it relates to covering transportation and as it relates to other costs. These are some photos from this program in the Belize situation. So we have these wonderful little children, these Mayan children for whom their first language is definitely not English, but they would need to be proficient in the English language in order to succeed in their space. And so what happens is that rovers, so young ladies are trained, they're assigned to different homes, and they're placed into spaces to ensure that families are not being left behind. And you can take a look here at the family. The houses are not very fancy. Many of these persons are deemed in the low socioeconomic bracket, and so, you know, mommy stays at home, daddy's out working, and there's not a lot of money going around. The project is a wonderful idea. It is a project that could perhaps be mirrored here in the Barbadian context. Why I'm saying this is because we continue to recognize that many of our children are not getting that early intervention that you're hearing the presenters speaking of. So what can we do? Are we going to keep going forward? Because the gap keeps getting wider and wider and wider. How feasible is it for us to meet at a corner? Practitioners, the government, parents, church, how can we meet to ensure that we are not leaving these boys and these girls behind? And I would have done some research, as I mentioned, in the Belizean setting, and many of these homes were void of pencils. There were no crayons. There was nothing. You had some plantains, perhaps. You had the cooking section, but there were no cognitively stimulating materials available for these students. And so what I did is I did some research to find out if I introduced these types of materials into their homes, if it would impact on emergent literacy skills. And you would imagine it did make a great impact. And my research shows that this access to the cognitively stimulating materials impacts in terms of getting them aware of those letter sounds. They start to learn a little bit more about color recognition. So all of those foundational skills that we would want them to have in a center setting, they're able to learn it in a home space while attached to this specific rover. This program has demonstrated the ability to contribute to building human and social capital. We want our students to be able to contribute to the Barbadian setting. We don't want to leave anybody behind, but sadly we are. So it calls for us to think a bit more about the models that we are going to introduce in our society to make sure that the literacy development of our boys and our girls is really considered. Again, you know, our clip isn't showing, but what we would have done with this same child, we took an intervention into his school space, not his home space, because mommy was working, and we were able to take a PAL. So we kind of mirrored it here in the Barbadian setting, and we sent a practitioner into his space at school. And just as how the study would have shown, giving him access to these resources improved, he was able to develop these fine motor skills that we know to be important. He was able to develop number recognition. He was able to develop color recognition just because we shifted the model. So rather than letting him just come to school and flop through the system, we didn't know what he can do, we didn't know what he can become. We did something to make sure that he was able to achieve the goals that were set for him. So again, as I close, I want you to consider this word corner. How can we meet? How can two sides meet? Where can we meet? Because we're leaving quite a few students behind. And there's simple things that we can do to ensure that we can connect with them and to ensure that they're able to live out their God-given potential. Thank you so much for listening.
Thank you, Ms. Murray. Thought-provoking. Yes, thought-provoking. It's question time, and I know we are all hungry. So we're giving you the opportunity to pose 2 questions to our presenters. Any questions at this time? All right, we have someone approaching the microphone. Hi, good afternoon. Yes?
In regards to the last presentation, if I was interested in being a part of that, how would I go about serving?
All right, so you're hearing me a bit better. All right, so through Edison Teachers Training College, you can make contact with me there, and I'd be happy to get you on the team. Okay. More than happy.
Good, thank you. One other comment.
I just want to comment, if I may. That word corner has my mind in a word. I will continue to think of the word corner when I leave here. But in our culture, we are not usually accustomed to making home visits. And as you speak about home visits, it might have to become part of us, supervised, because it's a very sensitive thing to do. All the reading would suggest that going to the home and so on has to have so many things in place to protect you as the person who is going to help, and then the family as well, confidentiality, safe space, etc. But it is a really beautiful thing, and I would commend you on any work that you would have done with the children, because sometimes we do see children feeling uncomfortable at school. Mm-hmm. And this is something that can be done. Mm-hmm. So continue to work at it, and I'm sure you will get the support. Thank you so much.
Thank you. One final. Yes? Ms. Grenada?
I'm concerned about the literacy rate, the children who are being left behind. Because I have had the privilege of attending skills training, and I came across a number of young men who in that category. And I could see in my mind, I haven't done any studies, that the crime situation in the island is linked with that literacy rate. They go to school and they fall through the cracks. And I have studied the book, Barbados Most Wanted. And I don't just read it for reading's sake. I read it and I look at the lifestyle of the people, Barbados Most Wanted, in that book. And I can see the trend, the home base, the education, and the literacy. And I personally believe there's a strong link between that children who get left behind and just get into crimes. And I feel if we're going to apart from God, that's important, if we're going to solve the crime situation, we have to pull them up and fill that gap you're talking about.
Thank you so much. Ladies and gentlemen,
Sorry, I just want to say quickly to the last presenter, we had started, or we are in the process, Ms. Carter and myself, looking at the same concept that you spoke about, but we were looking at doing it in community centers, where we train women in community centers to help develop the children within their community centers, and this would have been for children who are not able to make it to daycare centers. So we're starting at that level to help the mothers in the community, not only for literacy, but to do activities. So when you first said corner, I said activity corner, so I thought that that's where you were going. But to work in the communities with young women, so it will be women helping women within the community.
And your ideas, I am happy that you've shared that, but the difference is that the Roving Caregivers Program happens in the home, because if we think about Vygotsky and the zone of proximal development, you want parents to know how to do things. So if you take them to the community, that's great, but are they going to be in the community where their parents are present, so that the parents are seeing best practices, they're seeing exactly step by step what you're supposed to do if my child makes this mistake, and that C don't say K and D don't say D. So it means that you have to have a way to guarantee that that parent knows what you know. And if you pull the parent away from the intervention, it be just duplicating things that have already been done.
It's like, bringing like the mother and the child,
right,
in a setting where women are helping each other in that particular setting.
Yeah. And if I may say, colleagues, there is a role for both approaches.
Yeah, for sure.
Both approaches, yes, and we can continue to explore. We are talking about building the partnerships and so on, so we can continue to explore both ideas with a view to see how we can come together to make it happen. With a view to seeing how we can come together to make it happen. Much food for thought. Final.
Yes, please. Good afternoon. I'm listening to all the conversations and the questions. I'm not sure if the panel also knows that your social worker is in the room. And I'm also listening to her idea. So I'm saying we are thinking and we are talking about partnerships and collaboration. So utilize us, because we have the
Thank you so much.
knowledge, so we all can work together.
Yes. Thank you. Building the partnerships. At this time, I'm going to hand over just a few more minutes more. I promise you, you will enjoy that lunch. We're going to make some presentations, and I'm going to hand over to Mrs. Carter.
Thank you so much, Dr. Morris. I'm going to ask our presenters, starting with Mrs. Boyce, to come. We're just going to give a little token of our appreciation. Those who would have presented before, we're going to get theirs to them.
I'm trying to get it out. I don't want to do anything wrong.
You need this
I
as well?
think this is mine.
And just before we break for lunch, I have a surprise for two persons in this room. I'm going to ask Kimberly Rollins to come. Kimberly was the very first person to register for this symposium. And I'm going to ask Ira Walcott-Smith to come. She was the first person to register for both days. So ladies, please come. I know they're very surprised. Congratulations, Ira. This is for you. Thank you so much. Congratulations, Kimberly. Thank you so much.
It's lunchtime. Please remain seated. The ushers will come and they will direct you to the buffet table. Those of you like me who have finished eating, I hope you have enjoyed your meal. I am cognizant that some of you are still eating and do continue to eat and enjoy while we prepare for the third and final segment of today's program entitled Trauma and Special Education. Our first presenter for the afternoon will speak on the topic Early Childhood and Trauma. I am pleased to introduce to you Dr. Joanne Brathwaite Drummond. Dr. Brathwaite Drummond holds a double bachelor's degree in medicine and surgery from the Mona campus of the UWI. This was awarded in 1997. She continued in Jamaica for 6 years, working in the fields of primary care and emergency medicine. After returning to Barbados in 2003, she pursued a doctorate of medicine in psychiatry with the University of the West Indies, and later a master's degree in public health with the University of Liverpool. Dr. Brathwaite Drummond is currently a consultant community psychiatrist with the Psychiatric Hospital, Ministry of Health and Wellness, and she has responsibility for the Winston Scott, Edgar Cochrane, and St. Philip Polyclinic catchments, including the district hospitals. She's also an associate lecturer with the University of the West Indies, teaching psychiatry at both undergraduate and graduate levels. Please welcome Dr. Brathwaite Drummond to the podium.
Good afternoon, everybody. Thank you very much for that introduction. I am not sure how well you can see the slides, but I am hoping that I can get through the presentation. I think I have about 15 to 20 minutes. It's a large, pretty broad, very important topic, but I'll see what we can get through, and hopefully we can have some questions if anything is not clear in the plenary discussion following. So the UNCRC defines a child as every individual under the age of 18, unless there is law in that area, in that locale, that says differently. And as you would be aware, in Barbados, we do have that little bit of a gray area where a 16-year-old can consent to sex, but they can't actually consent to get themselves out of the possible fallout that can result from sex. It's important for us to know that childhood, early childhood, in medicine we often look at it as birth to 8 years of age, and it's a very important stage for a child. It's a stage where significant brain development is supposed to occur, and at that time, parenting needs to be very strong, very consistent, very loving, and children need to have an environment that is appropriately stimulating in order for that development to occur. We also want to be working during the presentation with a definition of trauma that refers to an incident or series of incidents, and I want us not to miss that it can be a single incident, doesn't have to be anything ongoing, sometimes once really is enough, where a person experiences such an event that is emotionally disturbing. It may or may not be life-threatening, but certainly has lasting adverse effects in every single domain of that individual's life. Now, there are several different types of trauma. This is not an exhaustive list. Certainly it will include things like natural disasters and commercial sexual exploitation and war and things like that. But the vast majority of trauma that children experience occurs in places where they're supposed to be safe, where they're supposed to be protected, and it's with caregivers and at the hands of caregivers, unfortunately. So we're talking about places like home, extended family homes, school, and church. So there are some risk factors that can increase the risk of a child being abused, and this is certainly no fault of their own. But if you have a child under the age of 4 years, just by virtue of being in that age group, less than 4, or during adolescence, if you're unwanted, and that's a no-brainer, if you're not wanted, if parents don't want you or caregivers don't want you, or you don't meet their expectations, and it is alarming the unreasonable expectations that some kids live with when we see children in the mental health clinics. If a child has special needs, if they cry persistently, if they need more care than, say, the average child would, if they have abnormal physical features, if a child has an intellectual disability or a neurological disorder, or if they identify as being LGBTQIA, then certainly that increases their risk of being traumatized, whether by caregivers or by others. When we look at the factors related to the caregiver, you can see by far there are way more. If a parent does not bond with a newborn, they're unable to nurture that child. If they themselves have experienced trauma in childhood or they've been maltreated in some way, if they don't understand what normal development for not just all children, but their child is supposed to look like, that can also lead to unrealistic expectations and increases the risk of abuse. Obviously, parents who are misusing substances, whether during the pregnancy or throughout the child's life, because we do have some cases where parents consistently abuse substances. If the caregiver has low self-esteem, poor impulse control, if they themselves have an intellectual or neurological disorder, if they're involved in criminal activity, and this last one kind of throws an umbrella over every parent almost in Barbados. If that parent is experiencing, or caregiver is experiencing financial difficulties, then the risk of abuse increases. There are also societal factors. When persons come from societies where there's gender and social inequality. So you may have, for example, a household where you have a male child and a female child, and their experiences are very different. The male child may have more privilege, more freedom, whereas there might be an undue burden placed on a female because a male is preferred in that particular household. If we don't have the policies and programs that would actually prevent maltreatment, where families are supported, if we don't have a legislation that actually deals very decisively and quickly with incidents of childhood maltreatment, then those are the things that are actually going to increase the risk from a societal standpoint of abuse. Now, when we look at the scope of the problem, I don't have any local data, and I only hope that maybe a speaker who went before, or maybe someone who is going to come after, has access to that. But certainly when we look at it from on a global perspective, what WHO lets us know is that 3/4 of children between the ages of 2 and 4 regularly experience some kind of abuse. That is actually a very alarming number. And when we look at it from the point of view of sexual abuse, sexual related trauma, then we see that both men and women, and you can see it says 1 in 5 women and 1 in 13 men report. And that's the important thing, report, because the men tend to underreport. Males tend not to report sexual abuse as often as do females. So although it looks like the women take the greatest burden there, unfortunately we may actually have a lot of abuse occurring in males that is not reported. So, consequences of childhood trauma. Well, the first thing is that it's often not seen. And when something isn't seen or it's unrecognized, then it goes untreated. There's no intervention, and it unfortunately continues. And childhood maltreatment that leads to childhood trauma impairs a person's health, every aspect of health. So physical health, mental health, social and occupational health. And that has far-reaching consequences, as we'll see, because the mental health of the individual is, that's the seed. But coming out of that, the health of the family, and then the mental health of the entire community and our nation is actually impacted. So for every person that we have who is experiencing childhood trauma, there's a ripple effect, and that is actually impacting the nation. So it's not just a matter of what's happening to that child or even that family. The effects are actually impacting the entire population. So what are these effects? So physical health problems, depending on the type of trauma a child experiences. You can have something as simple as bumps and bruises, or you can have things like organ damage, loss of function. I've seen children who've lost an eye, who have been unable to have children, who've had to have a hysterectomy at the age of 2 or 3 years because of sexual abuse and things of that nature. So it can be very, very severe. Mental health, which is my wheelhouse, as you would have heard, I'm a psychiatrist. The list there is long, but let me just say that childhood trauma is bad for mental health. It's as simple as that. There is no severe mental illness that is in the Diagnostic and Statistical Manual of Mental Disorders that does not have an increased risk if a person has childhood trauma. So any childhood trauma, especially if it's severe, increases a person's risk of having a mental disorder, not just in childhood, but in adulthood. So if you take nothing more than this away from my presentation, childhood trauma is really, really, really bad for mental health in childhood and beyond. There are also social problems that will result, so chronic relationship difficulties, and that then can result in poor parenting and perpetuation of childhood abuse. Because remember, when we looked at the risk factors that are related to the caregiver, if they have been abused or they have suffered trauma in childhood, then their risk of abusing their children goes on. So this is where we keep seeing this perpetuated. They also have occupational problems. So children who have, and I'm sure there are some teachers here who would have seen children who have a history of abuse, their academic functioning may not necessarily be what is expected when you look at their level of intelligence. And from that follows on the risk of underemployment or unemployment, financial difficulties, occupational dysfunction. And we talked about unemployment and financial challenges increasing a caregiver's risk of abusing a child or traumatizing their child through neglect or abuse. So again, you can see where this cycle is going to be set up. And as I said, because an individual's mental health ripples out and impacts families and communities, what happens is that when we have significant rates of childhood trauma, child abuse, and their effects on physical and mental health in these individuals, you can be investing in a country, you can be investing in infrastructure and technology and so on, but if we're not actually investing in the mental health of our children, our parents, and our future parents, then you can actually realize that you're not going to see the type of economic and social development in the country, because we're putting in the money, but what is supposed to be governing how our individuals function in different spheres of life is not where it should be. So you can actually not see the return on investment in other areas if you're not dealing with mental health. How do we prevent childhood trauma? Because that's really the best thing, not trying to fix it after it has started. I always say it's very hard to unring a bell. So if we can prevent, that's great, and it requires a multi-sectoral approach, parent and caregiver support, education and life skills. We need criminal justice on board, support services, child protective, criminal justice. So we need a multi-sectoral approach if we're going to prevent. But as I'm sure everybody here knows, we are not always able to prevent. So what are the signs of childhood trauma? In preschool children, it may look like separation anxiety, or the flip side of that, being fearful of caregivers. Children might be very fretful, they cry a lot, they may feed poorly, they might be losing weight, you may see them complain of nightmares or having a sleep disturbance of another type. In primary school age children, common signs would be becoming anxious or fearful when there isn't a trigger, expressing feelings of guilt or shame, having difficulty concentrating, again, sleep difficulties. And at the secondary level, you may hear articulations of being depressed or feeling alone, social withdrawal, so not interacting with peers. You may see the development of eating disorders, non-suicidal self-injury, so cutting, burning, things of that nature, or frank suicide attempts. They may start to abuse substances, and you may see precocious sexual activity in that group. Finally, how do we manage childhood trauma? General medical and mental health examinations are required. Often when we have a case of child abuse, it's a combination of pediatrics as well as psychiatry, psychology that come together to do an assessment for a child. We may need to involve the criminal justice system as well as child protective services, depending on how the child is being traumatized, why they've been traumatized, what area of life this is happening in, whether it's a problem with the caregiver, whether it's a problem at school, whether it's a problem at church. Because often, I have seen children who have been kind of pulled off the street by the random stranger and traumatized in one way or another. But the vast majority of childhood trauma, as I said, occurs in situations and areas of life where children should be safe and expect to be safe. Trauma-informed therapy, including cognitive behavioral and supportive psychotherapy, are of benefit, and it's not 1 or 2 sessions, it's not a little counseling. Often persons who experience significant childhood trauma require years of psychotherapy. I sometimes see persons come into my clinic in their 50s or 60s, and they're talking for the first time about abuse that they have experienced in childhood. Sometimes that's not even why they have come, but in taking a psychiatric history, you've asked certain things about childhood and so on, and you'll see people who are in their advanced years, who have raised children and have grandchildren. When you ask them about their childhood, they break down into tears. The oldest person I've taken a history from who has spoken of childhood trauma and just broken down into sobs was a man who was in his 80s in one of the geriatric hospitals, cried like a baby about the abuse that he suffered and not being able to go to school because he was sent to work at a very young age because he had lots of other siblings and things of that nature. So this doesn't just go away. We tend to sweep things under the rug, but this can last with people for life. So when you think therapy, don't think a couple of counseling sessions, especially if the abuse is severe. People do need a lot of help to get past childhood trauma. Family therapy is often indicated, and in some cases we do have to use medications if a person has clinical depression or an anxiety disorder, post-traumatic stress disorder, or another serious mental illness. So I think that gives me time. I have a few references, and I'm quite happy to make the presentation available to you if you desire. Thank you so much. Do I take questions now, or do we just wait? At the plenary. Great. Thank you so much for your time. Goodbye.
As we continue to explore the subject of trauma and special education, I am pleased to introduce to you Ms. Lee Carter, peripatetic teacher in the Student Support Services section of the Ministry of Education, Technological and Vocational Training. And she is here to share with us on the topic of early intervention, the importance of early intervention. Let's welcome her. Yes.
I see it. Good afternoon, colleagues. Great, excellent. Yes, good, good. All righty. Now, can you see what it says? Can you read this for me? It says, your child's future starts here. Now, this afternoon, it is my pleasure to be able to speak to you on the importance of early intervention. Now, I don't know if you know what a PT is, a peripatetic teacher is, but what has happened over the last 4 years is I have had the opportunity to have a wider scope. I am a teacher, but I have the opportunity to move around and to see the actual impact that early intervention makes for our students. Now, I have a question for you. How many of you are teachers? By raise of hands, good. Now, in how many of your classrooms do you have students who have special needs? Okay, good, right? So I say that to say that I found that early intervention really, really is important. Now, so what we want to look at today is early intervention. What is it and why is it important? So what is early intervention? Early intervention, as it relates to the area of special needs education, basically looks at the process of providing services, education, and support for young children who have been diagnosed with a physical or mental condition. So there may be children in your context who have diagnoses, and there's a high probability that that diagnosis or that condition will result in a developmental delay, or there may be others who have a delay and they are at risk of having challenges, but there's no diagnosis. Now, what is early intervention? Now, in the context of special needs education, early intervention actually is a systematic structure of coordinated services. They basically promote the child's age-appropriate growth and development, and they also offer support during the critical years. So, early intervention is not a random process at all. In its most pristine state, It is a system of coordinated services that look at how do we best allow our child or the student to be able to optimize his or her, in terms of his or her development. So it isn't random. It should begin with screening by a trained early childhood development professional like a pediatrician or an early interventionist to determine if the child could have developmental disabilities. And then through the screening, the evaluator's goal is to gain a more comprehensive understanding of the child's history. Good. So, in its most basic form, it requires screening the child for developmental delays. It requires the development of a therapy plan. It looks at the monitoring of that progress, of that process, and it looks at providing support and guidance for the parents and caregivers. Now, we would have used the term developmental delay. Now, this term simply means that the child has not attained the developmental milestones at the expected time. So a developmental delay may be a major or minor ongoing delay in the process of development. So who is eligible for early intervention? Now, some of the general areas in which you might find delays in development may relate to a child's cognitive development, his or her physical development, their development in terms of communication, their social and emotional development, or their adaptive development. And adaptive development just relates to self-care and personal responsibility. So how is the child able to perform his or her daily tasks, daily routines like eating, dressing, toileting? A child may also have a developmental delay in one or more of these areas in terms of their gross motor skills. So using the large groups of muscles to sit, to stand, to walk, keep balance, change position, or they may have delays in terms of their fine motor skills. So their fingers, using their hands to eat, to draw, to dress, play, or to write. You may also find that a student has delays in terms of his or her language skills. So speaking, using body language, their gestures, communicating, understanding what others say. They may also have challenges in terms of their cognitive skills. So thinking, including learning, understanding, problem solving, reasoning, cooperating, responding to the feelings of others in terms of their social skills, interacting and having relationships with others. Now, who is eligible for early intervention? Students can receive intervention services from birth through to their 3rd birthday and sometimes even beyond that. Now, a child who qualifies for an early intervention program may receive one or more of these services. So, screening and assessments, they may have tests in terms of hearing, audiology, or vision services. There may be home visits. There may be a need for medical, nursing, or nutrition services, physical or occupational therapy. Physical and occupational therapy would basically help students to develop and enhance their fine motor skills, their sensory processing abilities, self-help skills. Early interventionists may engage the children in play-based activities and look at developing independence and how this improves their overall function. So for some students who would qualify for it, you might also have psychological services, social work services, speech and language therapy that would focus on improving their communication skills, such as vocalization, their language comprehension, and social interaction skills. You may also have, there may also be a need for transportation, right? So, special instruction for the child may also be provided in terms of early childhood education. You want to ensure as well that there are services that look at the child's cognitive development, that promote their social skills, that foster early learning through appropriate activities. You may also need things like physical therapy, which would again improve their gross motor skills, balance, coordination, and strength. Now, for some students, the need for early intervention is recognized from birth. So you know from the time the child is born that early intervention services will be essential in terms of helping this child grow and develop. And often this is so for children who are diagnosed with a specific condition at birth, or who may experience significant issues like prematurity, very low birth rate, illness, or surgery soon after being born. So some of our students who may have Down syndrome, students who may have microcephaly, cerebral palsy, hydrocephaly, it would be very evident that there is a need for early intervention in those cases. Now, for others, early intervention may be needed due to delays in development, like we've been talking about developmental delays. So some children would generally have a relatively routine entry into the world, relatively routine development in terms of their typical development, but then you might find that they develop more slowly than others, or they may develop in some ways that seem different to other children their age. Now, a diagnosis of a developmental delay is most often made by a professional, so it is not a random process like I would have said. It's based on an assessment. So what we would find in that case is that parents, caregivers, and teachers like yourselves are usually the first persons who would notice that a child is not progressing at the same rate as other children their age. And therefore, there will be the need for conversations and collaborations with parents, caregivers, pediatricians, and in some cases, there is the need for the use of a screening tool. Now, the pediatrician would be able to observe a child in terms of his or her delays using the screening tool, and it may require several visits and possibly a referral to a developmental specialist in order to be sure that the delay is not just a temporary one. So, your child's future starts here. What are the benefits of early intervention? At the very basic level, early intervention is key as it helps a child with a delay reach their highest level of functioning in a developmental area. Some of the other benefits that are found in early intervention relate to how it may enhance the development of a young child with disabilities by providing targeted supports and services. Now, when we talk about targeted supports and services, we need to be able to, through the assessment, identify the specific needs of the student, and from that place, be able to offer the services and the supports that are needed. Early intervention would also serve to reduce the educational costs by actually minimizing the need for special education through early intervention. We're finding more and more of our students are in need of placement. They're in need of special education services, but they have to remain in the general education context because the provision is not there. Now, some other benefits of early intervention is that it minimizes the likelihood of institutionalization and maximizes the possibility of independent living. One of my goals as a teacher is that goal of having my students become independent, move towards a place where they can be independent. They don't have to be a burden, basically, to the system. That is very, very critical and important. And early intervention measures help to address this area. Early intervention also provides the tools that parents would need. It helps with capacity building in families in order to be able to educate them so that then they can meet the needs of their children more readily and more efficiently. So generally, early intervention has wraparound gains. It has gains for the child with disabilities, because that child would gain in terms of his or her cognitive, physical, language, and social skills. It also benefits families because it helps families be able to better manage the needs of the student, needs of the child, and it also would reduce the incidence of stress. It would then benefit the entire society. Yes, because it reduces the need for institutional placement and the need for special education, and it also saves money. Now, as it relates to research, there's research that speaks to the actual role and the impact of early intervention brain research. Now, when children are developing in those formative stages, there's an excess of synapses. Synapses in the brain basically are the neurons that would communicate with each other, that connect and communicate with each other. And there's an excess of synapses produced by a child's brain in the first 3 years that makes the brain particularly responsive to external input. So it is very critical that during that period, and that we understand that during that period, the brain can actually capture experience more efficiently than it would be able to do later when there is a pruning or a cutting away of the synapses. Yes, so early intervention, again, is very, very, very critical. As it relates to other research, there is research that speaks to specific components that support healthy brain development. And as you can see, one of them is intervening early. Early intervention is one of the things that has been highlighted to support healthy brain development in our children. There's also good nutrition, nurturing experiences, taking care of the caregiver, developing a sense of safety amongst them, and good nutrition, nurturing experiences, intervening early, a sense of safety, and taking care of the caregiver. So in essence, developing and learning is cultivated through the child's nature and nurture, biological maturation, and his or her experience. Early interventions would have profound effects on a child's development and learning through optimal periods of development. There are certain periods, not that it is impossible because of what we call neuroplasticity, but there are certain periods of development that are the best periods or better periods of development. Yes? So, research also says that early intervention programs are important because they provide evidence-based services to young children using a family-centered model. A family-centered model, when we have our interventions, we are also providing for the parents. So it builds their competency, it builds their capacity, and it supports them in terms of addressing the needs of their children. Early intervention is also very, very important because services are specifically tailored to each child's unique needs, and they encompass various disciplines. Early intervention has also been shown to enhance social and emotional skills to promote school readiness. There are lots of our students, lots of our children who are not ready for school. They need to be, the skills to come into school have to be developed. And through early intervention programs, supports, and services, that can be done. It can also strengthen the relationships that they have with their families and contribute to their overall success in adulthood. So early intervention literally builds our students' future through the structures that are provided in these early years that set them up for growth. Yes, it is. Research also says that early intervention allows it to be less likely that there will be a cost later in life. 1 in 3 infants and toddlers who received early intervention services did not later present with a disability or require special education services. Therefore, early intervention not only impacts the child, but it impacts the entire community through education and guidance. Early education really is at the forefront of supporting families through its initial diagnosis, family-based interventions, and in shaping their views on delay and disability. Ultimately, the significance of early intervention can be found in its ability to improve a child's developmental trajectory, enhancing the long-term outcomes and contributing to their overall well-being. Thank you very much.
Thank you very much, Ms. Carter. Again, lots of food for thought as we reflect on our individual endeavors, whether it's in the classroom setting, whether it's in the caregiver, nursery school, daycare setting, a lot to think about as we listen to the various presentations. And we seek to see how, as practitioners, we can assist in this process of early intervention through being observant and reporting any change in behaviors and so on, and seeking assistance from the various external agencies and individuals. Setting boundaries and discipline. That's the next topic on today's schedule. And our presenter is Miss Natasha Hasselgrave, Lead Behavior Analyst, Behavior Change Barbados. Is Miss Hasselgrave here? Right behind me? Yes. Welcome. Please, let's give her a round of applause as she shares with us on this topic, setting boundaries and discipline.
Thank you. Hello, everyone. How's everyone doing? Good. I know you've had a long day and you've got a lot of information, so I'm going to try and be very on the point. I'm a very chatty person, so I'm going to follow notes and try and behave. Those of you who know me, have worked with me, you know that setting boundaries and discipline is an interesting topic for me to present on. So I'm going to do so with my spin. I am a behavioral analyst. I follow the principles of ABA, which is Applied Behavioral Analysis, which focuses on positive reinforcement primarily. So let's try and do this. Okay, so I would like everybody to try very hard to keep a very open mind. I'm going to try and change the way everybody views behavior. So this is generally what I want to talk about today. So what is behavior, the environments and its role, consequences, punishment and reinforcement, individual differences, the function of behaviors, and talk a little bit about the hard ears child and motivation. So this is what we are going to use as our definition of behavior. Human behavior is everything people do, including how they move, what they say, think, and feel. So this is a general example that everybody can relate to. So opening a bag of chips is behavior. How you're thinking how good those chips are going to taste is a behavior. Reading the sentence on this board is a behavior. Holding your pen, your paper, these are all behaviors. So with that in mind, this is kind of where I'm going. So minus my typo, behavior is usually used in reference to a class of responses sharing a specific function. So these words are in bold because they're going to be very important for the rest of my discussion. So as we know, behavior is now thinking about anything that we're going to say or anything we are going to do. A response is going to refer to the specific instance of a behavior. So a few examples I have here are eating behavior, greeting behavior, and writing behavior. Okay, so we're going to talk about the environment. So the environment is an extremely important part of this. All behaviors occur within an environmental context. The environment influences a behavior primarily by physical features, when they occur, and the effect on the behavior. So, environments can be a classroom, a home, in your car. Let's look at, when you're driving and you're having road rage, you act very different in your car when you're angry at a driver than you do in a bank, right? I have a horrible singing voice, but I will sing to the top of my lungs in my car. That is the only place that's going to happen. So these are examples of how the environment triggers different behaviors within us. So I have a very bad habit. Does anyone have a really bad habit? Thank you. My very bad habit is I crack my knuckles. The first thing I do every time I get inside my vehicle is I push all of my fingers against the steering wheel and I crack all of my knuckles. I have tried over and over, and I'm a behavioral therapist, so I should have been able to do this. I cannot stop cracking my knuckles because every time I get in my car, I'm going to push on the steering wheel. I'm not even thinking about doing it. It's automatic. So I'm going to continue to do it in that environment. Does that make sense to everybody? I'm going to keep asking for participation. Don't worry. Okay, so what affects behavior in the environment? So we have the antecedent, which is anything that is going to occur before a behavior happens. Then we have a consequence, which is anything that happens after a behavior. So back to my road rage example. You get cut off, or you have somebody driving very silly on the road. You then have your antecedent. You then engage in your behavior of screaming, shouting, beeping the horn. Your consequence is you generally feel better, right? That's really the only helpful that's causing. So this is how we look at behaviors. You find what's triggering the behavior, which is typically the antecedent, and you find the consequence. The challenge right here is also to look at consequence in a different way that is not something negative. We have been taught, and it's just our language, that consequence means something negative is happening. So in this, we're going to use consequences as just what happens after the behavior. So let's see how it looks. So this is an example of conditioned behavior, which is just behaviors that we have learned to do. So the environment that is triggering your behavior is you see a drink machine, right? You're super thirsty, you've been talking at a podium all day, you deposit the coin into the machine, you press the button, that would be your behavior, and your consequence is you're gonna get a cold drink. You're going to continue to do this behavior because you're thirsty and you want a cold drink. Same thing, a friend says, "What time is it?" Sorry, your friend is asking you, "What time is it?" You reply, the friend says, "Thank you." You're reinforced for speaking. If your friend was to ignore you, you're gonna say something and you're not gonna wanna answer them next time. So the consequence is what is going to determine, I'm actually jumping ahead, so hold on. Now we're gonna look at unconditioned behaviors. These are things that happen naturally, so your reflexes. So your throat is irritated, you cough, it feels better. You touch a hot stove, you pull away your hand because you're removing the pain. So these are automatic, whereas the conditioned ones are the ones that we've been taught through experience usually. So now we're going to look at using consequences to affect the future. I'm very behind on my notes. So all behavioral consequences affect the rate of a response that will be emitted in the future under the similar conditions. So if it works for you, you will continue to do it. If it doesn't work, you're not going to continue to do it. So essentially what we're saying is consequences are going to determine if a behavior you are doing is going to increase or decrease. I have here a note that the conditions are most sensitive to whatever happens immediately after a behavior occurs, because that is what is associated with that behavior. So again, your consequence has to happen immediately for it to have an effect on that behavior. Delayed consequences sometimes do, but generally not in the beginning anyways. So we're going to talk about how we alter a rate of behavior. So we kind of have to pause and take a step back from, the ideas that we have of what reinforcement and punishment are. The reason I say this is because we have this misconception about punishment and reinforcement. Reinforcement is not bribery. First of all, bribery is where you give somebody something first and then you expect them to do something. Reinforcement is where you provide essentially a reward after something is done. So reinforcement is the most important principle of behavior and the key element in behavior change. Positive reinforcement is when a response is followed immediately by the presentation of a condition that results in a similar response occurring more often. Whereas punishment is a response that's followed immediately by a condition that will result in the behavior happening less often. So again, it's not punishing meaning bad, it means it's actually decreasing a behavior. So with that in mind, why does everybody go to work? Other than your drive and your passion and your love for what you do, why do you go to work? Shout it out. You get paid. You are reinforced for going to work every single day, right? Why, when you see a police officer, do you slow down on the road? Automatically. Why do we do this? Exactly. We're avoiding a ticket. So our behaviors are always being changed by our environment. You can drive as fast as you want when you don't see a police officer, but as soon as you see them, you're going to slam on the brakes. No, I do not do this. So now we're going to get to the part about individual differences. So based on those two examples, which are generally wide set examples, we're going to look at how people respond differently to the same set of environmental conditions. So it's not a one-size-fits-all when it comes to reinforcement and punishment. I'm trying to think of a good example. If you have a child, for example, who doesn't like to be tickled. I work with kids and I do this very often. I tickle kids. You will come across a child who hates to be tickled. So I'm thinking I'm being super fun and no, it's fun, and I tickle them and they scream and they retract and they pull away and then they won't have anything to do with me. I've ended up punishing them for doing something that I was trying to reward them because I assumed something that I thought was reinforcing is going to be reinforcing to them. So it is very individual. So I know we highlighted there's a lot of teachers here. The idea is it is not ever going to be a one-size-fits-all. There is going to be a majority rules, like most kids like candy. If you offer candy, most kids are going to do anything you want. However, it's not going to always be that easy, and the specifics of every individual's uniqueness is what's going to alter that behavior, because that's our goal. We're looking at altering behaviors. So again, because you think it's reinforcing doesn't mean everybody else thinks it's reinforcing. So we're going to go to some of the whys behaviors occur. So this is true for us, children, everybody. So there are 4 functions of behavior. Behavior occurs for sensory, escape and avoidance, attention, and usually access to a tangible. So we're going to break them down. So sensory is where a learner, and again, learner because this applies to everybody, enjoys the movement, it feels good, right? So kids on the spectrum, for example, will flap, they'll rock, they'll chew on things. It feels good to them. We shake our feet, we click pens. I have a habit of I'll pull on my hair when I'm super focused. So we all do these things that help us because they just feel good. So escape and avoidance. This is where the learner gets away from an aversive stimulus and avoids coming in contact with an aversive stimulus. So again, when a child doesn't want to do an activity and they engage in a tantrum or they're running away or they try and destroy the activity. There's also positive examples as well with this because, like again, the police, we slow down, we're avoiding it. So again, speed limits, eating lunch on time, avoiding that feeling of hunger pains, canceling a call when your boss calls on a weekend and you don't have to deal with that. You know, paying a bill online instead of going and having to stand in line at SharePay. These are all ways that we avoid and escape punishment that we feel are punishing, essentially. The next one we're going to look at is attention. So the learner is gaining attention for social interactions from another person. Kids will do this a lot in a maladaptive way, from screaming and crying or throwing items. We do this by social media posts. You know, how many hearts did you get? This is, you know, it's motivating because it's attention. The clothes that you wear when you feel good, and you know. So these are, again, kids and us in terms of people. These are all functions that we experience. So tangibles, wanting to gain access to a specific item or activity. So again, a child is told no, they have a tantrum, they scream, they hit, they bite. These are ways that they're going to react because they want a tangible. Again, the same thing with us. You answer your phone when your friend calls because you want access to that conversation. You pay the cashier for the groceries because you want food in your house. Pay the light and power bill because you want electricity. So you're gaining access to tangibles in all of these situations. So again, when you're comparing it with kids, whether it's a workplace or a home place, these are the same functions that we function off of that they are using as well. Sorry. Okay, so now we're going to have a little bit of a discussion about the hard ears child. As you can see, just based on my background, the whole discipline and setting boundaries. Boundaries I believe in, very hard. Discipline for me means a little bit of a different word. So hopefully you guys are following along. So we have this saying where there are no bad children. There are bad behaviors, do not get me wrong. But the idea is it's not the child. It is a learned response they have gained based off of their experiences and consequences. So if it's reinforced, it will continue. If it's punished, theoretically it's reduced. However, punishment depends on the child. So, I'll give you an example. I observed a child in this classroom one time who was severely ADHD, like probably the worst I've ever seen up to that point. The child got so hyperactive, they were actually climbing on the desk while the children were working. So, what does the teacher do? She puts him at the door, right? He's disrupting the class. You have to remove him. You have to get him out of the classroom. What then ended up happening is every day the child did this. And then when the child wasn't sent to the door, he would ball up his activity and throw it. So what was actually happening was the teacher was reinforcing the child's non-preferred task escape, if that makes sense, to go stand by the door or to go to the principal's office because they didn't want to do the task to start with. So what they did worked. They were now allowed to skip that activity. So this is where I talk about the immediacy of the reinforcement or the punishment being after the behavior. Because yes, the child probably took that homework. You know, they probably sat in at lunch and did it. But at the time, it didn't make a difference to the child's behavior because it wasn't happening immediately after. So that's something really important to look at when you're trying to look at a consequence to provide a kid, whether it's reinforcement or punishment. It has to actually work with the behavior. It has to happen with the behavior. So again, immediate consequence is where we're going to see the behavior change happen. So there's my little implementing boundaries moment. So for any child, boundaries are set when expectations are provided and follow through is present. So you have to follow through with what your expectations are. A lot of these kids, again, this area is special needs. They don't actually understand. They're just following a routine of behavior. So sometimes I like to tell people to kind of get a blanket mindset and see what the child knows instead of expecting what the child knows. The reason I say to do that is not because you shouldn't expect anything from the child, but it allows you to be a little bit more aware of where their deficits are. So before I jump ahead, a child doesn't know the rules. We want to teach them the rules. They're going to learn through consistency. We learn what we are exposed to. So the consistency, the reinforcement, that's how we're going to learn. A child will thrive with structure. Everybody in here knows this. Providing structure allows a reduction of anxiety, increases the independence, and the skill building. So discipline in my field should be approached with extreme care. So discipline, I actually had to look this up because I was a little unsure. Discipline is the act of providing punishment when disobedience occurs. So fine, that's great. One size does not fit all for discipline either. If you think of, if you rob a store, you go to jail. However, people are still robbing stores. So it's not a huge discipline. They're being punished in our world for being disobedient or not following the law, but it's not actually curbing a lot of the behaviors. Yeah, it does for some, don't get me wrong. But generally, the kids that we're talking about are not one size fit all and are not fitting the bill for every intervention that you're able to use in your wheelhouse. So what I want to propose is when you're providing some type of discipline, that you're using a method that I call it the walk, don't run method. But essentially all it is you're teaching a skill while telling a child not to do something. So the child's running in the classroom. The first thing we innately are going to say is stop, don't, stop. They may stop, but they're going to continue to do it. The idea is you want to tell them what to do. You can say don't run, but then tell them walk. Tell them the ball goes outside. Because the thing is when they do it that way, you can say, nice listening, good job. And again, I'm focusing on the positive reinforcement, and you will be finding yourself reinforcing things that you just expect the child to do or that they should be able to do or theoretically know better. But again, going back to this hard-ears child, we want to make it look a little bit more like, well, why are they not getting it? And sometimes it's something simple as nobody's actually shown them what to do. So when to seek support, again, based on these, you guys are all now professional therapists, and you're going to be able to identify the function of the behavior. You can find suitable replacement behaviors. So example, think of the walk, don't run situation. Teach the skill. If you don't see it, teach it and then call for help. This child's not able to learn. This child is not understanding this area. And then you can figure out what else is going on. Because again, it's not always just a delay, there's so many elements that can affect a child. Adapt your teaching methods. Not every child is going to learn the same way, but again, you guys know this. Understand the child, what skills they have, and then adapting those expectations based on where they are and teach them to where you want them to be. Just adding to your workload. The main thing is motivation. So, work example. You guys have to now come to work on Saturday and you're getting $1 more. Who's showing up to work on Saturday? Right? If you need a little extra money and you're now offered $300 a Saturday, okay, maybe some Saturdays, right? That's also depending on your environment. So we're going now back to the environment, which is going to increase the behavior's chance of happening. So motivation is going to strengthen or it's going to weaken the value of the consequence that you're trying to use as a reinforcer. So because, again, you think that giving a child one sticker is going to make them be super happy for doing a whole week of good sitting and nice behavior, they might not think so. So the idea is, again, it's a little extra thought, but the idea is to work in the motivation that's going to keep them going. Because think the same thing. You wouldn't do it for less either. So give them that same push and pull. So my take-home message. I think I've gone way too far, sorry. So we're going to look at children differently from now on. We're going to use the typical behaviors are typically behaviors are communication. And they're falling under those 4 functions. They want attention, they want something, they're trying to avoid you, and it just feels good. So we're going to alter these behaviors by teaching replacement behaviors. We're going to find that motivation and reinforce them. So my everyday example is when you try and do a diet, you change your routine, you eat differently, you exercise, you count calories, etc. The change or the consequence is you gain muscle or you lose weight or whatnot your goal is. But if you only look at losing weight, you're not going to get there because you're not doing the behavior change that's going to get you there. So the consequence has to follow the behavior, not be the focus of where we want. So again, the summary, which we've pretty much just done, everyone has behaviors. We aim to increase appropriate, decrease the maladaptive. We do this most effectively through positive reinforcement. Be aware of individual differences. Remember, behavior is communication. Teach the new skills. And it takes time and consistency. It is not an overnight fix, and there is no magic stick, no matter how many times people ask for it. The end. On the couch?
Yes. Oh, two questions. Dr. Bradford Drummond. Yes, colleagues, again, a lot of food for thought as we explore the area of trauma and special education. This is your opportunity to ask the question. 2 questions. Who wants to go first? Yes, Shelly Ann, please. You can use the nearest microphone.
Okay, good afternoon, everyone.
Good afternoon.
Thank you very much, colleagues, for such interesting and informative presentations. I'm going to pose my question to, I think, Ms. Carter.
Yes.
And maybe other colleagues from the ministry in terms of early intervention. I'm going to just preface my question with just a few comments, just to say that for those who are not aware, UNICEF is based here, but we work in 12 countries in the Eastern Caribbean. And over the last year, let's say, as I move around and I do my visits with the ministries in the other islands, one of the major issues that keep coming onto our desk is that there appear to be more children being diagnosed is not the right word, being observed with autistic-like behaviors, because a lot of them don't have an official diagnosis. So I have 2 questions, really. One is this a similar situation for Barbados? Are you also feeling like there are more children demonstrating these behaviors? And 2, in terms of early intervention, what are some of the actions that you're already taking, or at least what are the theories behind it? Thank you.
Okay, good. Yes, please. We have also been recognizing that there has been a significant increase in the number of students who are demonstrating tendencies that are autistic, and then the number that are actually being referred or diagnosed with autism. What we have tried to start to do is to equip teachers with strategies that they can use. So in Teach, in the program, where there is a structured approach to teaching and instructing students who may be on the spectrum. We've done that. We're also looking into doing further teaching with teachers across the system. We did it initially with educators in early childhood, as a part of one of our initiatives in the ministry through student support services, and we're continuing to do so because we are recognizing that the number of students, in terms of the referrals that we receive, that those numbers are increasing.
Okay, thank you very much for that. I guess I'm not sure, I know that you're from Ministry of Health, but in terms of, again, we've been talking about our integrated services for early childhood, those wraparound services that look at the whole child. Where is Barbados, I guess, in terms of the link between screening and early intervention through the health ministry, and how is that connecting and dovetailing with Ministry of Education in terms of making sure that those children who have early red flags, for example, are getting the services that they need? And that question could also be for Dr. Morris, if she has a quick answer.
What happened? As you would have indicated, there is a significant need for there to be a partnership between the Ministry of Education and the Ministry of Health, because what we recognize is that most times the children that would present would be those who are initially seen through AC Graham. So we have been working on building that relationship. What we want to do also is to ensure that the referrals that are that they're not duplicated. So we are in the process of actually developing that relationship, the communication. We've had meetings. We had a meeting as recent as, you were in that meeting, in May. We recently had a meeting in May so that we can develop that relationship and that collaboration, because we recognize that it is very essential to being able to make gains.
Yeah, it is essential. Thank you so much for that. Thank you.
I would like to pose one question to Dr. Drummond. This is in relation to the services of the Child Guidance Clinic, which I believe is located within the compound of the psychiatric hospital. What are your views on how we can go about changing mindset as it relates to the stigma associated with the Child Guidance Clinic and where it is located, and how can we treat to that and to assure our parents and caregivers that there's more to the clinic than where it's located?
Okay, well, one of the things that I would say is that in recognizing that there was significant stigma associated with the psychiatric hospital itself, the Child Guidance Clinic had been moved out to the Brantford Tate Polyclinic and had been operating there several days a week. I think at one point they were able to provide service every day, every weekday. Then we had COVID, and because Brantford Tate was one of the testing sites, and there was significant disruption to all healthcare services, not just mental health services provided through Child Guidance. They lost their space and so on at that clinic, and then they had to go back into the psychiatric hospital. So it hasn't always been there. Okay. The hope is to have it back out in the community as soon as the clinic at Brantford Tate can accommodate them. Mm-hmm. With respect to stigma, it's not just child guidance, it is in fact mental health, mental illness in general. The psychiatric hospital, as a part of one of their 5 community mental health action plans, has a fairly robust anti-stigma campaign. You may have heard some of the spots on the radio, there have been posts on social media and so on, trying to reduce stigma, not just with respect to mental health issues in childhood, but in general. So education, certainly, it would be very good if we can actually have greater interaction with teachers, guidance counselors, PTAs, because as you said, there is significant stigma. But I think a lot of the times it's so much more difficult for persons just to get in the door. But once they get there, they do realize that the service that they're accessing is going to be beneficial for them, for their child, but certainly more public education is necessary to reduce stigma overall. But that's something that the hospital is working on fairly assiduously at this time.
Thank you very much. Ladies and gentlemen, we have come to the end of what I consider to be an excellent day of knowledge sharing, exchanging of ideas. I hope that you have been taking note and that you are ready and raring to go and to be back here tomorrow when we will actually get down to looking at action items and how we can move forward together in the future to continue to do the very best for these young children who have been entrusted in our care in the several settings, whether it is daycare, nursery schools, primary schools with nursery units. I would like, on behalf of the organizing committee, to express my gratitude to all of the presenters who gave of their time and their talent and their expertise today. I would also like to, yes, please, applause. I would also like to express gratitude to you, the participants. Thank you so much for responding to the invitation. Overwhelmingly, we were very, very pleased with the response. And again, we look forward to seeing you here tomorrow as we continue to engage, as we continue to build the partnerships which have started here. I said to Mrs. Carter this morning, this is the inaugural. And I have challenged her and her team in partnership with the partners to ensure that this happens again in a couple of years. Thank you to all of the persons who work so hard behind the scenes to ensure that everything happens. Thank you very much to our technical team, and we look forward to having their services again back here tomorrow. And in their absence, I want to thank the caterers for providing us with the meals today. Do travel safely, and we look forward to you gracing us with your presence tomorrow. Thank you so much.